The Art of Critical Thinking, a novel, a story of thinking, failing, and learning to think again. Prologue, the question that changed everything. The conference room on the 42nd floor of the Aldrich building smelled of expensive coffee and quiet desperation. Rain streaked the floor-to-ceiling windows overlooking Manhattan, turning the city below into an impressionist painting of lights and shadows. Dr. Sarah Chen stood at the head of the mahogany table, watching 12 of the brightest minds at Meridian Pharmaceuticals avoid her gaze. For the past 3 hours, they had been circling the same problem like moths around flame, getting nowhere. "Let's go over one more time," Marcus Webb, the VP of Research, said with barely concealed frustration. The Phase 3 trials for Neuraxin show a 15% improvement in cognitive function for early-stage Alzheimer's patients. That's exactly what we need to move forward to FDA approval. The data's clean, added Jennifer Park, lead statistician. P-value under 0.05. Confidence intervals well within acceptable ranges. By every metric, this is a success. Sarah watched the heads around the table nod in agreement. She'd seen this pattern before. Smart people, confronted with data that confirmed what they wanted to believe, abandoning the very rigor that had made them successful in the first place. "There's something wrong with the study," Sarah said quietly. The nodding stopped. "I'm sorry." Marcus's voice carried an edge that could cut glass. "Sarah, we've been over this. The methodology was sound. We followed every protocol. The peer reviewers found nothing wrong." "I didn't say there was anything wrong with the methodology," Sarah replied, pulling up a slide on the screen behind her. "I said there's something wrong with the study. Look at the dropout rates." The screen showed 2 columns of numbers. In the control group, 8% of participants had withdrawn from the study. In the treatment group, the dropout rate was 23%. "Dropouts are normal," Jennifer said, though her tone had lost some of its certainty. "People move. They get tired of coming in for appointments. They experience side effects they don't want to talk about," Sarah finished. "I spent last week calling the participants who dropped out. 17 of them. You know what I found?" The room had gone very quiet. 11 reported significant side effects, vivid nightmares, episodes of confusion, in 2 cases brief but terrifying hallucinations. They didn't report them to the study coordinators because they were afraid or embarrassed or because the symptoms seemed unrelated. When they dropped out, we marked them as lost to follow-up and moved on. Marcus leaned back in his chair. "Even if that's true." "It is true. I have their statements recorded." "Even if that's true, the data still shows improvement in the remaining patients." "Yes," Sarah said. "In the patients who didn't experience side effects severe enough to make them quit, we've accidentally selected for people who tolerate the drug well, and then claimed those results apply to everyone." The implication hung in the air like smoke. If they moved forward with the FDA application based on incomplete data, they'd be putting a drug on the market that could harm the very people they were trying to help. If they disclosed the dropout findings, they'd have to redesign the study, delaying approval by at least 2 years and putting millions of dollars of investment at risk. "Why are you doing this?" Marcus asked. And for the first time, Sarah heard something other than defensiveness in his voice. It sounded almost like genuine curiosity. "Because 3 years ago, my mother was diagnosed with early-onset Alzheimer's," Sarah said. She's 62. "Every day, I watch her lose pieces of herself. So, believe me, I want this drug to work more than anyone in this room. But she taught me something important. The truth doesn't care what we want." She clicked to the next slide. "We have a choice. We can push forward with what we want to believe, or we can step back and ask better questions. We can look for data that confirms our hopes, or we can look for data that challenges them. We can be smart, or we can be wise. But we can't be both unless we're willing to be wrong." The rain continued to fall outside. Inside, something shifted, not dramatically but noticeably. Jennifer pulled out her laptop and started pulling up the raw data files. Marcus rubbed his face with both hands and sighed. "All right," he said finally. "Let's start over. But this time, let's actually think." 6 months later, Sarah Chen stood in a different conference room, this one at Boston General Hospital. The revised study protocols had revealed something unexpected. Neuraxin did work, but only for a subset of patients with a specific genetic marker. The drug company had initially seen this as bad news. A smaller market meant less profit, but it also meant they could target the treatment precisely, avoiding side effects in patients who wouldn't benefit anyway. The FDA had fast-tracked approval for personalized screening. Her mother, it turned out, had the marker. She'd been in the new trial for 3 months now, with no side effects and measurable improvement. As Sarah looked out at the audience gathered for her lecture, medical students, researchers, a handful of journalists, she thought about the moment in that conference room when everything had hung in the balance. The moment when the question, "What if we're wrong?" had changed everything. Critical thinking, she began, isn't about being smart. If it were, smart people wouldn't make catastrophic mistakes. And they do, all the time. I've made them. You've made them. We'll make them again. She clicked to her first slide, a simple question mark. Critical thinking is about developing the courage to ask questions when everyone else has stopped asking them. It's about looking at what you want to be true and having the discipline to ask. But is it? It's about understanding that your mind, as powerful as it is, comes with systematic flaws, and learning to work around them. She paused, meeting eyes in the audience. It's about recognizing that the same intelligence that can solve equations and design experiments and write symphonies can also trick you, deceive you, lead you confidently toward disaster while you nod and smile and congratulate yourself on being rational. Another click. The screen now showed a maze. Over the next 10 weeks, we're going to explore the landscape of human thinking together, not as a lecture series, but as a journey, because critical thinking isn't something you learn once and file away. It's something you practice every day, in small decisions and large ones, in moments of certainty and moments of doubt. She thought of her mother, who'd taught philosophy at Columbia for 30 years before the disease began its slow theft, who'd always insisted that the most important question wasn't what do you think, but how do you know? My mother used to say that the unexamined life isn't worth living. I used to think that was melodramatic. I don't anymore, because I've seen what happens when smart people stop examining their assumptions. I've seen the cost of incurious certainty. Sarah clicked to the final slide of her introduction, a photograph of a door, slightly ajar, with light streaming through the gap. Someone once told me that learning to think critically is like learning to see in color after a lifetime of seeing in black and white. You don't realize what you've been missing until suddenly you can see it. She smiled. Are you ready to see it? In the audience, a young medical student named David Okonkwo leaned forward in his seat, pen poised over his notebook. He'd come to this lecture because it was required for his program. He'd expected to be bored. Instead, he found himself thinking about every decision he'd made in the past year, every diagnosis he'd been confident about, every time he'd dismiss a colleague's concern because he'd been sure he was right. He thought about the patient last month, Mr. Patterson in room 347, whose symptoms he'd attributed to anxiety, when it turned out the man had been having a series of small strokes. Mr. Patterson had survived, barely, but David had been so certain. He wrote in his notebook, underlining the words twice. How do you know? He didn't realize it yet, but his life was about to change. They all were, because critical thinking, once learned, can't be unlearned. Once you see the mechanisms of your own mind, you can't unsee them. Once you understand how easily you can be wrong, you can never be quite as certain again. And that, paradoxically, is what makes you more likely to be right. The lecture hall lights dimmed. Sarah's voice carried across the room, steady and clear. Let's begin. Chapter 1. The Mirror in the Mind. David Okonkwo had always considered himself a rational person. He graduated top of his class at Johns Hopkins, published 2 papers before finishing his residency, and possessed what his professors called exceptional clinical judgment. He was good at making decisions quickly, trusting his instincts, moving forward with confidence, which was why, 3 days after Sarah Chen's lecture, he found himself sitting in his car in a hospital parking lot at 2 a.m, unable to turn the key in the ignition. His hands were shaking. It had started during morning rounds. He'd been presenting a case, a 47-year-old woman with persistent headaches, when Dr. Chen, who'd been invited to observe the teaching hospital's neurology department, asked a simple question. Why do you think it's migraines? David had rattled off his reasoning. The patient's age, the pattern of symptoms, the family history, the normal CT scan. It was textbook, clean, obvious. Those are all reasons it could be migraines, Sarah had said gently. I asked why you think it is. The distinction had seemed trivial at first, but as the day progressed, David found himself unable to stop thinking about it. He'd gone back to review the patient's chart. He considered other possibilities. He'd realized with growing unease that his certainty had been based less on evidence and more on pattern matching. He'd seen dozens of migraine cases that looked like this. So this must be a migraine case too. When the patient's follow-up MRI revealed a small meningioma, a slow-growing tumor that the CT had missed, David had felt the ground shift beneath his feet. He hadn't been wrong because he was stupid. He'd been wrong because he'd stopped thinking. Now, in the darkness of the parking lot, David pulled out his phone and found Dr. Chen's email address on the hospital directory. His thumb hovered over the screen for a long moment before he started typing. Sarah Chen's office at Boston General was smaller than people expected, barely large enough for a desk, 2 chairs, and floor-to-ceiling bookshelves crammed with neuroscience journals, philosophy texts, and what appeared to be a complete collection of detective novels. Sherlock Holmes, Sarah explained when David's eyes lingered on the books during their meeting the next afternoon. I've read each one at least 10 times. My mother gave them to me when I was 12. I wouldn't have pegged you as a mystery fan, David admitted. The best critical thinkers usually are. Mysteries are puzzles about thinking itself, about what we notice and what we miss, about the difference between what seems true and what is true. She gestured to one of the chairs. You said you wanted to talk about self-awareness? David sat down, still not entirely sure how to articulate what he'd been feeling. I keep thinking about what you said, about how our minds trick us. I thought I was good at this, at thinking clearly, making decisions. But yesterday, the meningioma case. You heard. Dr. Ramirez mentioned it. He was impressed. Actually, said most residents would have doubled down on their original diagnosis rather than ordering the additional imaging. Sarah leaned back in her chair. So why does it bother you so much? David was quiet for a moment, choosing his words carefully. Because I was so certain. I looked at that patient, and I saw exactly what I expected to see. I didn't even consider alternatives. And the scary thing is, I felt like I was being thorough. I felt like I was thinking. But you weren't thinking, Sarah said. You were recognizing. There's a difference. She pulled a piece of paper from her desk drawer and drew a simple diagram. 2 circles, one labeled System 1 and one labeled System 2. Daniel Kahneman's framework, she explained. System 1 is fast, automatic, intuitive. It's pattern matching. You see a situation that looks familiar, and your brain instantly retrieves similar situations from memory and jumps to a conclusion. System 2 is slow, deliberate, analytical. It's actual thinking, considering alternatives, weighing evidence, questioning assumptions. David studied the diagram. So System 1 is bad? No. System 1 is essential. If you had to consciously think through every decision, you'd never get anything done. When you're driving and someone cuts you off, System 1 slams on the brakes before System 2 even realizes what's happening. That saves your life. Sarah tapped the paper. The problem is that System 1 thinks it's always right. It delivers answers with complete confidence, and unless you've trained yourself to recognize when to be suspicious of that confidence, you'll just accept whatever it tells you. How do you train yourself to recognize that? That's what self-awareness is. It's learning to observe your own thinking, to notice when you're pattern matching versus actually analyzing, when you're feeling certain versus actually being certain, when your conclusion comes from evidence versus from what you want to believe. Sarah stood and walked to her bookshelf, pulling down a worn leather journal. This is something my mother taught me. She called it metacognitive journaling. Thinking about your thinking. Every night, I write down 3 decisions I made that day and examine why I made them. Not just what I decided, but what was happening in my mind when I decided. She opened the journal to a random page and read aloud. Tuesday, March 15th. Decision. Approved Dr. Martinez's research proposal without requesting revisions. Why? Initial reaction. The methodology looked sound and the hypothesis was interesting. But actual reason. I was tired. It was the last proposal of the day, and Martinez is a friend. I wanted to be done, and I wanted to say yes to him. If I'm honest, I didn't read it as carefully as I should have. Tomorrow, review it again properly. David felt something click into place. You question yourself on purpose. I examine myself on purpose. There's a difference. Questioning yourself constantly is just anxiety. Examining yourself regularly is wisdom. She handed him a blank notebook. Try it for a week. 3 decisions per day. Write down what you decided and why you think you decided it. Then go deeper. What were you feeling? What did you want to be true? What evidence did you actually have versus what did you assume? David took the notebook, running his thumb along its spine. What if I don't like what I find? Sarah smiled slightly. That's the point. Self-awareness isn't comfortable. It's like turning on a light in a room where you've been stumbling around in the dark. Suddenly you can see all the furniture you've been tripping over. Some of it is embarrassing, but at least now you can see it. That evening, David sat at his kitchen table with the notebook open in front of him. His roommate, Jake, a software engineer at a startup, was making dinner and providing a running commentary about some technical problem at work. So I'm telling them the architecture is fundamentally flawed. Jake said, chopping onions with more force than strictly necessary. But the senior devs are all attached to it because they designed it, right? Classic sunk cost fallacy. David looked up. Sunk cost fallacy? You know, when you keep doing something because you've already invested time or money in it, even though it's not working, like when people sit through a terrible movie because they paid for the ticket. Jake scraped the onions into a pan. The code base is the movie, and they've paid for way too many tickets. David wrote that down in the notebook. Are you taking notes on my analogy? Jake asked, amused. I'm taking notes on my thinking, David said. Or trying to. Dr. Chen gave me this exercise. Examine 3 decisions I made today and why I made them. Sounds painful. It is, actually. David stared at the blank page. I can remember the decisions, but trying to figure out why I made them is harder than I expected. Like, this morning I prescribed antibiotics to a patient with bronchitis. Easy decision, right? Standard treatment. But why? Was it because the evidence supports it? Or because that's what I always do? Or because the patient seemed anxious and I wanted to reassure them by prescribing something? Or because I was running behind schedule and writing a prescription was faster than explaining why they might not need one? Jake turned from the stove, interested now. Which one was it? I don't know. That's the problem. I remember making a decision, but I can't remember the actual thinking behind it. It's like my brain just decided and I went along with it. Maybe you didn't really think about it at all. David looked at his roommate. That's what scares me. How many decisions do I make every day without actually thinking about them? The next morning, David arrived at the hospital 45 minutes early. He'd spent the previous evening filling 3 pages in a notebook, and the exercise had left him feeling simultaneously enlightened and disturbed. He'd examined his decision to order the antibiotics, his choice to skip the gym, his assumption that a colleague was angry with him based on a brief text message. What struck him most was how often his reasoning was actually rationalization, his brain making up logical-sounding explanations for decisions that had been driven by emotion, habit, or convenience. He found Sarah in the neurology conference room, reviewing scans. I think I'm doing this wrong, he said without preamble. Sarah glanced up. How so? Every time I try to figure out why I decided something, I realize I'm just making up stories. Like, I'll write down, I decided X because of reasons A, B, and C, and then I'll realize that A, B, and C are just what I want the reason to be. The actual reason was probably something less flattering. That's not doing it wrong, Sarah said. That's doing it right. You've just discovered confabulation. Confabulation? The brain's tendency to create false memories or explanations without intending to deceive. It's a well-documented phenomenon in neuroscience. When we're asked why we did something, our brain instantly generates a plausible story, and we believe that story, even though it might not be accurate. She pulled up a new scan on her computer. There's a famous experiment by Michael Gazzaniga with split-brain patients, people who'd had the connection between their brain hemispheres severed. He'd show an image to their right brain, which couldn't produce language, and the patient would respond to it physically. Then he'd ask their left brain, which controls language but hadn't seen the image, why they did what they did. And the left brain would just make up a reason, confidently, convincingly, completely wrong. David felt a chill. So, how do we know when our explanations are accurate? We don't. Not completely. But we can get better at catching ourselves in the act. Sarah turned to face him fully. The fact that you're noticing the difference between your real reasons and your stated reasons means you're developing metacognitive awareness. You're starting to see your mind at work. It's unsettling. It should be. You're essentially installing a security camera in your own brain. Some of what you see on that footage won't be pretty. She smiled slightly, but it's better than not seeing it at all. Over the following weeks, David found himself paying attention to his thinking in ways he never had before. He noticed when he jumped to conclusions. He caught himself cherry-picking evidence that supported his initial diagnosis while dismissing contradictory data. He recognized the feeling of certainty and learned to treat it with suspicion rather than confidence. He also noticed patterns in his thinking. He was more likely to make snap judgments when he was tired. He was more dismissive of alternative possibilities when he'd already committed to a diagnosis in front of other people. He was more likely to order unnecessary tests late in the day, when his analytical thinking was depleted and he defaulted to defensive medicine. The awareness was exhausting at first. It felt like being followed around by a skeptical commentator who questioned everything. But gradually, something shifted. The voice became less of a critic and more of a guide, not undermining his confidence, but refining his judgment. One afternoon, David was examining a patient, a 19-year-old college student named Emma Harris, who'd come to the ER with severe abdominal pain. The initial workup suggested appendicitis. The surgeon had already been called, but something nagged at David. The pain pattern wasn't quite right. The timing felt off. 6 months ago, he would have dismissed the feeling and moved forward. Pattern matches appendicitis. Therefore, it's appendicitis. Now he paused. Why do I think it's appendicitis? Because it looks like appendicitis. But what exactly looks like appendicitis? The location of pain, mostly. What doesn't match? The progression of symptoms. The patient's description of how the pain developed. He requested an additional test, a transvaginal ultrasound, over the surgeon's objections. The ultrasound revealed a ruptured ovarian cyst, not appendicitis. Different treatment, different outcome. Good catch, Dr. Ramirez said later. What made you think to check? David considered the question carefully. Not the automatic answer, but the real answer. I didn't feel as certain as I should have felt, he said finally. I recognized that my brain wanted a pattern match to appendicitis because it was the obvious answer. When I noticed that feeling, I realized I needed to actually think instead of just recognize. Dr. Ramirez studied him for a moment. You've changed these past few weeks. More careful, but somehow more confident too. What happened? I learned to see myself thinking, David said. Turns out I was getting in my own way. That evening, David met Sarah for coffee at a shop near the hospital. She'd suggested they discuss his progress. The metacognitive journal had been her assignment. After all, I wanted to thank you, David said as they settled into a corner booth. This whole exercise, it's changed how I practice medicine. Maybe even how I live. Sarah stirred her coffee thoughtfully. Tell me what you've noticed. Specifically, David pulled out his notebook, now nearly full. I've noticed that my first instinct is wrong more often than I thought. Not always wrong, but wrong enough that I can't just trust it. I've noticed that my certainty and my correctness aren't correlated. Sometimes I'm most certain when I'm most wrong. I've noticed that I'm influenced by things I didn't realize influence me, whether I like a patient, whether I'm hungry, whether I'm worried about looking stupid in front of colleagues. Those are profound observations, Sarah said. But here's the question. Now that you've noticed all of that, what do you do about it? I question myself more. I slow down before making decisions. I look for evidence that contradicts my initial impression. Good, but there's a trap there too. Sarah leaned forward. Self-awareness can become self-doubt if you're not careful. The goal isn't to second-guess every decision or to paralyze yourself with uncertainty. The goal is to recognize when your thinking is reliable and when it isn't. David frowned. How do I tell the difference? Experience. Pattern recognition, the good kind. Over time, you'll learn what your reliable intuitions feel like versus what your unreliable ones feel like. You'll develop a sense for when to trust your System 1 and when to engage System 2. She took a sip of coffee. But that takes practice, and it takes honesty about your own patterns. Like what? Like recognizing your cognitive signature, the specific ways your mind tends to go wrong. Everyone has one. Mine, for instance, is that I tend to overcomplicate things. When I'm stressed, I see complexity everywhere, even when the simple explanation is correct. So I've learned to notice when I'm doing that and ask myself, am I being thorough or am I overthinking? David considered this. I think my signature is overconfidence. When I know a lot about something, I assume I know more than I do. I extrapolate from partial information. That's a valuable insight. Now you can watch for it. When you feel very confident, that's your cue to be extra careful about checking your assumptions. Sarah smiled. That's what metacognition gives you, not perfection, but a better error correction system. They talked for another hour, ranging across topics. The difficulty of maintaining self-awareness when you're busy, the social pressure to appear certain even when you're not, the difference between productive doubt and destructive anxiety. As they were leaving, Sarah pulled a book from her bag and handed it to David. Read this when you get a chance. It's about cognitive biases, the systematic ways our minds mislead us. Think of it as the next level of the work you've been doing. David looked at the cover. Thinking Fast and Slow by Daniel Kahneman. More homework? He asked with a smile. More tools for your toolkit, Sarah corrected. Self-awareness is a foundation. But to really think clearly, you need to understand the specific ways your mind can fool you. That's what we'll talk about next. Late that night, David sat at his kitchen table with the book open in front of him and his journal beside it. Jake had gone to bed hours ago, but David couldn't sleep. His mind was too active, too energized by the connections he was making. He wrote in his journal, "Today I realized something important. I spent my whole life learning how to think about the world, chemistry, biology, physics, medicine. But I never learned to think about my thinking. I never questioned whether the lens I was using to view the world might be distorted." Sarah said self-awareness is like turning on a light in a dark room. She's right. But it's also like looking in a mirror for the first time and actually seeing yourself instead of what you want to see. It's uncomfortable. It's humbling. But it's also freeing. Because once you see how your mind works, how it jumps to conclusions, how it filters information, how it tricks you into certainty, you can start working with it instead of being worked by it. 3 decisions today. 1. Order the transvaginal ultrasound for Emma Harris. Why? Because I noticed I felt certain about appendicitis, and I've learned that my certainty is often unwarranted. The feeling of certainty was my cue to slow down and think harder. 2. Didn't respond to Dr. Martinez's email immediately. Why? Because I felt defensive when I read it, and I've noticed I write worse emails when I'm defensive. Waiting until I felt calm led to a better response. 3. Declined Jake's invitation to go out tonight. Why? Because I wanted to read and think. But also, and this is the part one don't like admitting, because I was afraid I'd say yes for social reasons, even though I genuinely wanted time alone. I've noticed I do that a lot. Agree to things to avoid disappointing people, then resent them for it. He paused, then added one more line. I'm starting to see myself. I don't always like what I see, but at least now I can see it. David closed the journal and looked out his window at the lights of Boston stretching into the distance. Somewhere out there, patients were making decisions about their health. Doctors were making decisions about treatment. People were making decisions that would change their lives. How many of them, he wondered, were actually thinking, and how many were just deciding, confident in conclusions they'd never really examined, certain of reasons they'd never really questioned. He thought of the Sherlock Holmes books on Sarah's shelf. Holmes had a famous line, "It is a capital mistake to theorize before one has data." Insensibly, one begins to twist facts to suit theories, instead of theories to suit facts. David smiled. Maybe that was the whole lesson. Right there. Don't theorize before you have data. And don't assume you have data when all you really have is pattern matching and wishful thinking. He opened Kahneman's book to the first chapter. There was so much more to learn. And for the first time in his life, he was ready to learn it, not just with his mind, but with awareness of how his mind actually worked. The journey had just begun. Chapter 2, The Tools of Reason. The lecture hall at Boston General held 60 people, but only 37 had shown up for Sarah Chen's second session on critical thinking. David noticed the empty seats as he settled into his usual spot in the third row. Next to him sat Rebecca Torres, a psychiatric resident he'd met at the first lecture. Half the people dropped out, Rebecca observed, flipping through her notes. Guess self-examination wasn't everyone's cup of tea. Their loss, David said, though he understood the impulse. The metacognitive journaling exercise had been harder than he'd expected, not intellectually, but emotionally. Looking honestly at your own thinking required a kind of courage he hadn't anticipated needing. Sarah entered carrying a stack of papers and what appeared to be a newspaper. She distributed the papers, blank except for a simple logic puzzle at the top, and set the newspaper on the desk in front of her. "Before we begin," she said, "I want to tell you about a murder trial I attended last year." The room quieted. The defendant was accused of killing his business partner. The prosecution's case was built on 3 pillars. 1. The defendant had a financial motive. His partner was about to dissolve their company. 2. The defendant had opportunity. He was alone with the victim the night of the murder. 3. The defendant's fingerprints were found on the murder weapon. Sarah walked to the whiteboard and wrote out the 3 points. The defense attorney stood up and said exactly one sentence. "My client is left-handed, and the murder weapon was fired with the right hand." The jury acquitted in 40 minutes. She turned back to the room. "What happened?" A medical student in the front row raised his hand. "The evidence didn't actually prove guilt." "More specifically?" David spoke up. "The prosecution presented evidence that was consistent with guilt, but they didn't prove the connection was necessary. All 3 pieces of evidence could be true even if he didn't commit the murder." "Exactly." Sarah drew a diagram on the board, 3 circles labeled motive, opportunity, and fingerprints, with arrows pointing to a 4th circle labeled guilt. "This is the difference between correlation and causation, between consistency and proof, between what looks like logic and what actually is logic." The prosecution made what seemed like a logical argument, but was built on a foundation of loose associations. The defense showed that the foundation didn't actually support the conclusion. She picked up the newspaper. "Logic is the architecture of thinking. It's the difference between a building that stands and one that collapses. And most people's thinking, if we're honest, is architecturally unsound." Sarah spent the next hour walking them to the fundamentals of logical reasoning. Deductive versus inductive arguments, necessary versus sufficient conditions, the structure of syllogisms. But unlike David's undergraduate logic course, which had felt abstract and disconnected from reality, Sarah grounded every concept in practical examples. "You're evaluating a patient with chest pain," she said. "The ECG shows ST elevation. What do you conclude?" "Myocardial infarction." Several people answered simultaneously. "That's inductive reasoning," Sarah explained. "ST elevation is strongly associated with MI, but it's not the only possible cause. You're inferring the most likely explanation from the available evidence. That's often appropriate in medicine. We can't always wait for absolute certainty. But you need to know that's what you're doing." She wrote on the board, "If MI, then ST elevation generally true, ST elevation present, observed. Therefore MI probable but not certain." Now contrast that with, if the patient has chest pain and ST elevation and elevated troponins and a history of cardiac disease, then we treat for MI. The patient has all 4. Therefore we treat for MI. That's deductive. If the premises are true, the conclusion must be true. David found himself scribbling notes frantically. It wasn't that the concepts were entirely new, but seeing them applied to medical decision-making made them suddenly urgent and relevant. Rebecca leaned over. "This is going to change how I do consults, isn't it?" Already has for me, David whispered back. After the lecture, a group of them gathered at a coffee shop down the street. The conversation quickly turned to the lecture's content, as if they couldn't quite let go of the ideas yet. The thing that got me, Rebecca said, stirring sugar into her coffee, was when she talked about assuming causation. I do that constantly in psychiatry. Patient is depressed and also has insomnia, so I assume the depression is causing insomnia. But maybe it's the reverse. Or maybe they're both caused by something else entirely. Medicine is full of those assumptions, agreed Thomas Park, an older resident in internal medicine. We see two things together and assume one caused the other. Sometimes we're right. Sometimes we're wildly wrong. David thought about his own recent cases. How many times had he assumed causation without really examining the logic? Sarah said something to me last week that's been stuck in my head. She said the brain is a pattern-matching machine, not a logic machine. We evolved to see associations and jump to conclusions because that was faster and safer than careful analysis. Logic is something we have to deliberately practice. Like exercise, Thomas said, the brain wants to be lazy. Logic is making it work. The conversation shifted to evidence, specifically how to evaluate it. This had been the second half of Sarah's lecture, and it had left David feeling simultaneously enlightened and uneasy. She absolutely destroyed that study I've been citing for 6 months, Thomas said with a rueful laugh. The one about Mediterranean diet and cardiovascular outcomes. I didn't realize the methodology was that flawed. Sarah had walked him through the process of critically evaluating research, examining sample sizes, checking for confounding variables, looking at who funded the study, distinguishing between statistical significance and clinical significance. It had been a masterclass in skepticism without cynicism. I think the hardest part, Rebecca said, is maintaining the balance, being skeptical enough to not accept everything at face value, but not so skeptical that you dismiss good evidence just because it's not perfect. David nodded. He'd been struggling with exactly that tension in his practice. After the meningioma case, he'd found himself second-guessing everything, ordering additional tests, questioning his own clinical judgment to the point of paralysis. That's where the logic comes in, though, he said, thinking it through as he spoke. It's not about being more or less skeptical. It's about having clear standards for what counts as good evidence, and then applying those standards consistently. Easier said than done, Thomas muttered. The next morning, David found himself in an ethics committee meeting, something he dreaded attending. The committee was reviewing a case involving a 15-year-old cancer patient who wanted to discontinue chemotherapy. The oncology team wanted to continue treatment. The parents were divided. The ethics committee had to provide guidance. Dr. Harold Simmons, the committee chair, opened the discussion. The medical facts are clear. Without treatment, the patient will die within 6 months. With treatment, there's a 30% chance of remission. The question is whether we honor the patient's wishes or override them in the name of giving him a chance at life. The discussion that followed was passionate but muddled. People spoke about autonomy, beneficence, the value of hope, the duty to preserve life. But David noticed something. Nobody was actually constructing clear arguments. They were expressing opinions, strongly held, but without logical structure. He thought about Sarah's lecture, about premises and conclusions, about the difference between feeling something was right and having reasons to believe it was right. David raised his hand. Can I suggest we structure this differently? What if we start by identifying our premises, the principles we all agree on, and then see what logically follows from those premises? Dr. Simmons looked surprised, but interested. Go ahead. David stood and walked to the whiteboard. Let me try. Premise 1. Patients have the right to make informed decisions about their own medical care. Do we all agree with that? Heads nodded around the room. Premise 2. Minors' decision-making capacity varies based on age, maturity, and understanding. Agree? More nods. Premise 3. We have a duty to protect patients from decisions that result from inadequate information or impaired judgment. Agree? Yes, but... Someone started. Hold on, David said. Let's just establish what we agree on first. Then we can see where we disagree. He turned back to the board. So if we accept those 3 premises, the question becomes, Does a specific patient have sufficient decision-making capacity to make the specific decision? That's an empirical question, not an ethical one. We can assess his understanding, his reasoning ability, whether he's depressed or in pain that's affecting his judgment. The room was quiet. Then Dr. Simmons spoke. That's actually helpful. We've been arguing about principles when we actually agree on the principles. The question is whether they apply in this case. The discussion that followed was more focused, more productive. They agreed to have a psychiatrist assess the patient's decision-making capacity and to ensure he fully understood both the consequences of stopping treatment and the details of what continuing treatment would involve. If he demonstrated capacity and maintained his decision after a full assessment, they would honor it. As the meeting adjourned, Dr. Simmons pulled David aside. That was impressive. Where'd you learn to structure an argument like that? Funny story, David said. A neurologist taught me, by way of a murder trial. That evening, David met Sarah for their now regular coffee discussion. He told her about the ethics committee meeting. You applied logical structure to a values-based discussion, Sarah said. That's advanced work. A lot of people assume that logic only applies to factual questions, but it's just as important, maybe more important, when dealing with values and ethics. It felt strange, though, David admitted, like I was reducing something emotional and human to a logic puzzle. Logic doesn't eliminate emotion or values, Sarah said. It organizes them. It helps you see what you actually believe and why, and whether your beliefs are consistent with each other. She pulled out a sheet of paper and drew a diagram. Think of it this way. You have values, things you care about, principles you hold. You have facts, information about the world, and you have decisions, choices you need to make. Logic is the bridge that connects them. It helps you move from what you value and what you know to what you should do. She drew arrows connecting the three elements. Without logic, you're just floating in a sea of feelings and facts and choices, with no clear way to navigate between them. With logic, you have a map. The map doesn't tell you where to go. Your values do that, but it shows you how to get there. David studied the diagram. So when people say they're going with their gut or trusting their intuition, what they're really doing is skipping the logical bridge. Sarah finished. Sometimes that's fine. Your intuition is often right, especially in domains where you have lots of experience. But when the stakes are high, when the situation is novel, when emotions are running strong, that's when you need the bridge. How do you know when to trust intuition and when to demand logic? Sarah considered the question. That's metacognition again, knowing how you know. But here's a rule of thumb. If you can't articulate the logical structure behind your conclusion, be suspicious. If your reasoning is it just feels right, or it's obvious, or everyone knows, those are red flags. They often mean your system one is in control, and you haven't actually engaged in logical analysis. David thought about the times he'd been most confident and most wrong. They almost always fit that pattern. Conclusions that felt obvious, that he couldn't quite articulate the reasoning for, that seemed to require no justification. I made a list, he said, pulling out his phone. After your lecture, I went back through my recent cases and identified times when I relied on its obvious reasoning. Want to know what I found? Tell me. In 6 cases, the obvious conclusion was right. In 4, it was wrong. In 2 of those 4, it was dangerously wrong. He looked at Sarah. So, trusting my intuition gave me a 60% success rate. Those aren't good odds. Now try the same analysis for cases where you force yourself to articulate the logical structure of your reasoning. David smiled slightly. Already did. 92% success rate. Small sample size, but still. Logic works, Sarah said simply. Not because it makes you smarter, but because it makes your thinking visible. When your reasoning is explicit, you can check it for errors. When it's implicit, when it's just intuition or feeling, you can't. Over the next week, David found himself applying logical analysis everywhere. In patient consultations, in research meetings, in conversations with colleagues. He started noticing the structure of arguments, or the lack thereof. He noticed when people made claims without evidence. He noticed when evidence was presented, as if it proved something when it only suggested it. He noticed when conclusions didn't actually follow from premises, when analogies were treated as arguments, when correlation was assumed to be causation. At first, noticing these things was frustrating. It felt like everywhere he looked, people were thinking poorly. But gradually, he realized something. He'd been thinking poorly too. He just hadn't been able to see it. One afternoon, he was discussing a case with Dr. Linda Martinez, an attending physician who'd been his mentor. She was proposing an aggressive treatment plan for a patient with sepsis. "I don't think that's the right approach," David said carefully. Linda raised an eyebrow. "Why not?" In the past, David would defer to her experience or found a way to soften his disagreement. Now he thought about Sarah's framework: premises, evidence, conclusion. "Let me outline my reasoning," he said. Premise: we should choose treatments that maximize patient benefit while minimizing harm. Agree? Obviously. Premise 2: this patient has multiple comorbidities that increase the risks of the aggressive approach. Agree? Linda nodded slowly. Evidence: studies show that in patients with similar profiles, the aggressive approach has higher complication rates without significant improvement in outcomes. Conclusion: the standard protocol might actually optimize the benefit-to-harm ratio better than the aggressive approach in this case. Linda was quiet for a moment. Then she pulled up the patient's chart and looked at it again. "You're right. I was pattern matching to a different patient I treated last month. Younger, healthier. I wasn't actually thinking about the specific patient's risk profile." David felt a strange mix of vindication and discomfort. He disagreed with an attending physician and been right. But more importantly, the logical structure had made the disagreement productive rather than confrontational. They'd been able to examine the reasoning itself, separate from egos or hierarchy. "Where'd you learn to argue like that?" Linda asked. "I'm taking a seminar on critical thinking. The instructor says logic is the architecture of thought." She's not wrong. Linda closed the chart. "You know what? You should present at Grand Rounds next month. Talk about this, about how to structure clinical reasoning logically. I think people would find it valuable." David's first instinct was to decline. He was still a resident, still learning. Who was he to teach others? But then he thought about Sarah's lessons. What was his actual reason for declining? Fear of judgment, imposter syndrome, not logic. "I'll do it," he said. That night, David sat at his kitchen table preparing for the Grand Rounds presentation. Jake wandered in, grabbed a beer from the fridge, and peered over David's shoulder at the laptop screen. "The Architecture of Clinical Reasoning," Jake read. "Catchy title." Sarah suggested it. "She's a professor you keep mentioning?" "Neurologist." "But yes." David leaned back in his chair. "I'm trying to figure out how to explain why logical thinking matters without making it sound dry or abstract." Jake took a sip of beer. "Show them what happens when logic breaks down. People respond to failure more than success." David considered that. Medical errors? Sure. But also, doesn't have to be dramatic. What about everyday screw-ups? Times when smart people make dumb decisions because they're not thinking logically. Like what? Like... Jake thought for a moment. "Okay, at work last week, we had this major architecture decision to make. The team spent 3 hours debating it. Everyone had strong opinions. Finally, our CTO asked one simple question: what problem are we trying to solve? Turns out half the team was trying to solve one problem, and half was trying to solve a different problem. Once we clarified that, the decision became obvious." David started typing. "That's a premise problem. They were starting from different assumptions without realizing it." "Exactly. And they're all smart people. They just weren't thinking clearly because they weren't thinking structurally." Jake pulled up a chair. "You know what I've noticed since you started this critical thinking thing? You argue better. Better as in more? Better as in clearer. Like, we used to have these circular arguments where we both just restate our positions louder. Now you say things like, 'Okay, let's identify where we actually disagree,' or 'what evidence would change your mind?' It's annoying, honestly, because it's much harder for me to just be right." David laughed. "Sorry. Don't be. It's good. I'm learning from it." Jake finished his beer. "That's the thing about thinking well. It's contagious. Once you see someone doing it, you can't unsee it. You start noticing when you're not doing it. After Jake left, David returned to his presentation, but his roommate's comment stuck with him. It's contagious. That was the promise, wasn't it? Not just becoming a better thinker yourself, but creating an environment where better thinking was possible, where people could disagree productively, analyze collectively, build understanding collaboratively. He thought about the ethics committee meeting, about the discussion with Linda Martinez, about the conversations with Sarah. In each case, introducing logical structure hadn't shut down discussion. It had opened it up. It had created space for genuine exploration rather than defensive positioning. David pulled up a new slide in his presentation and typed, "Logic is not the enemy of creativity, intuition, or human values. It's the tool that helps us integrate them effectively. It's how we transform good intentions into good outcomes, strong feelings into sound decisions, deep values into practical wisdom." He paused and added, "And it's how we become people who can actually solve the problems we face, rather than just people who have strong opinions about them." Sarah would probably edit that. It was too grandiose, too sweeping. But it was also, David thought, true. He kept writing. The grand round presentation was scheduled for the following month. But David's relationship with logic had already shifted from student to practitioner. He found himself teaching colleagues, explaining frameworks, helping people structure their thinking. And he found that teaching others forced him to understand the concepts more deeply himself. When Rebecca asked him to explain the difference between necessary and sufficient conditions, he had to think carefully about medical examples. When Thomas wanted help evaluating a controversial study, David had to articulate his criteria for evidence quality. The journal he'd started at Sarah's suggestion now contained not just examinations of his own thinking, but observations about thinking in general, patterns he noticed, questions that seemed to unlock understanding, mistakes that seemed to recur. One entry, written late at night after a particularly challenging case, read, "Logic is humbling. It shows you how many of your confident conclusions rest on shaky foundations. But it's also empowering. It gives you tools to build better foundations, to construct arguments that can actually bear weight. I used to think being smart meant having quick answers. Now I think being wise means having good questions and a systematic way to work toward answers." Sarah says the goal isn't to become perfectly logical. That's probably impossible and might not even be desirable. The goal is to know when you're being logical and when you're not, and to choose appropriately. That's what I'm learning. Not to replace intuition with logic, but to use each where it works best, and to build bridges between them when necessary. David closed the journal and looked at the clock. 2 a.m. He had rounds in 5 hours. But his mind was still active, still processing, still building the architecture of better thinking. He smiled and turned off the light. Tomorrow, there would be more cases, more decisions, more opportunities to practice the art of reason. And each one would make him just slightly better at seeing clearly, thinking carefully, and helping others do the same. The tools were simple. The practice was hard. The results were transformative. That David was learning was the nature of any craft worth mastering. Chapter 3. The Shadows We Cast. Dr. Michael Brennan had been practicing emergency medicine for 23 years, and he trusted his instincts. When the 72-year-old woman came in complaining of back pain and shortness of breath, his gut told him it was musculoskeletal, probably a pulled muscle from gardening. He almost sent her home with ibuprofen. Almost. David Okonkwo, rotating through the ER that month, had asked a simple question. Have we checked for pulmonary embolism? Brennan had been annoyed at first. The patient's presentation didn't fit P. She had no leg swelling, no recent surgery, no long flights. But hospital protocol required following up on P concerns, so he'd ordered a CT angiogram. The scan showed multiple pulmonary emboli. Without treatment, the patient would have died within hours. Now, 3 days later, Brennan sat in Sarah Chen's lecture hall, looking distinctly uncomfortable. Sarah had invited him to speak about the case, not as a failure, but as an illustration. "I'm not here because I'm a bad doctor," Brennan said, his voice gruff but honest. "I'm here because I'm a human being, and human beings have brains that lie to them in very specific, very predictable ways." He clicked to a slide showing the patient's initial presentation. This woman didn't look like my mental image of a PE patient. She looked like the dozens of older patients I'd seen with back pain from arthritis or muscle strain. My brain said, this matches pattern X, therefore is pattern X. I didn't consciously decide to ignore other possibilities. My brain just didn't present them to me. Sarah stood and walked to the whiteboard. What Dr. Brennan experienced is called representative heuristic, judging the probability of something based on how well it matches your mental prototype. It's one of dozens of cognitive biases that affect our thinking, often without us realizing it. She wrote on the board, cognitive biases are systematic errors in thinking that arise from the brain's attempt to simplify information processing. David, sitting in his usual third-row seat, felt the familiar mix of fascination and disquiet that Sarah's lectures produced. Since starting the seminar, he'd become uncomfortably aware of how often his brain lied to him. Now, apparently, they were going to catalog all the specific ways it did so. The scary thing, Brennan continued, is that I felt confident. I looked at that patient, and I knew what was wrong with her. That certainly felt like knowledge. It felt like expertise. It was really just pattern matching gone wrong. Sarah nodded. Confidence and accuracy are not correlated in the way we think they are. Sometimes we're most confident when we're most wrong, because our brain has found a pattern match and stopped looking for alternatives. She advanced to the next slide, a list of cognitive biases with brief definitions. The list was long. We're going to focus on the biases most relevant to medical decision-making, but understand, these affect every area of life. Your relationships, your finances, your politics, your career decisions. These aren't occasional errors. They're the default mode of human thinking. After the lecture, David found himself in the hospital cafeteria with Rebecca Torres and a new face. Dr. James Patterson, a radiologist who'd started attending the seminars after hearing about them from colleagues. I counted, James said, stirring his coffee methodically. She listed 17 biases. 17 different ways my brain routinely lies to me. That's depressing. Think of them as bugs in the software, Rebecca suggested. Once you know they're there, you can write workarounds. Except we are the software, James pointed out. How do you debug yourself? David had been wondering the same thing. Sarah said something to me once. You can't eliminate biases, but you can build an error correction system. You can learn to recognize when you're likely to be biased and slow down. Slow down how? James asked. In the ER, I don't have time to sit around questioning my every assumption. You don't have to question every assumption, Rebecca said, just the ones that matter. Sarah's framework is high stakes plus uncertainty equals engage system 2. Low stakes or high certainty. Let system 1 run. David thought about the PE case. But Brennan was certain. That's the problem. The bias made him feel certain when he should have been uncertain. They sat with that uncomfortable truth for a moment. Okay, James said finally. So, how do we know when we're falsely certain versus actually certain? That, said a voice behind them, is exactly the right question. Sarah Chen set her lunch tray down at their table. Mind if I join you? Please, Rebecca said. We're trying to figure out how to recognize false certainty before it kills someone. Sarah smiled slightly. Welcome to the central challenge of applied epistemology. Here's what I've learned after 20 years of trying. You can't always catch in the moment, but you can build systems that catch it for you. She pulled out a notebook and sketched a quick diagram. Think of it like the safety systems on an airplane. Pilots are highly trained, but they still have checklists, co-pilots who can overrule them, and automated systems that warn them when something's wrong. They don't rely on their ability to never make errors. They build redundancy into the system. So, what's the cognitive equivalent of checklists? David asked. Several things. Decision rules, protocols for when to slow down and double-check. Social checks, deliberately asking others to challenge your thinking. Environmental design, structuring your workspace to make certain errors less likely. Sarah took a bite of her salad. For instance, Dr. Brennan now has a rule. Any patient over 60 with unexplained shortness of breath gets a PE workup, regardless of how unlikely it seems. That's a decision rule designed to override the representative heuristic. But we can't have rules for every possible bias, James protested. No, but you can develop metacognitive awareness of your own bias patterns. Everyone has their characteristic errors, the specific ways their mind tends to go wrong. Once you identify yours, you can watch for them. David thought about his journaling practice. He'd started noticing patterns in his mistakes. He tended toward overconfidence when tired. He tended to dismiss soft data, patients' descriptions of symptoms, in favor of hard data like lab results. He tended to see complexity where simplicity would suffice when he was feeling insecure about his competence. I think my main bias is confirmation bias, Rebecca said. Once I form a hypothesis about a patient's psychiatric condition, I start seeing evidence for it everywhere. That's probably everyone's main bias, Sarah said. Confirmation bias is like the master bias. It affects how we gather information, how we interpret it, how we remember it. It's why scientific method requires such rigorous structure. Left to our own devices, we'll just collect evidence for whatever we already believe. That evening, Sarah asked David to stay after the lecture. They walked to her office in comfortable silence. The hospital corridors quiet in that peculiar way. They got around 7 p.m., too late for day's shift, too early for night shift chaos. I want to talk about something we didn't cover in the lecture, Sarah said, closing her office door. Personal biases versus cognitive biases. David settled into the chair across from her desk. What's the difference? Cognitive biases are universal. Everyone has them, regardless of their beliefs or values. But we also have personal biases, prejudices, preferences, blind spots that come from our individual experiences and identities. Those are harder to talk about because they feel more personal, more like character flaws. She pulled out a folder and opened it. Do you remember the patient from last week? Margaret Williams, the elderly black woman with chest pain? David did. He'd been the admitting resident. What about her? How long did it take you to order pain medication? David felt his stomach sink. He knew where this was going. About 40 minutes. We were busy, and I was trying to rule out... David. Sarah's voice was gentle but firm. I pulled the charts for your last 10 chest pain admissions. 4 white patients. Average time to pain medication, 12 minutes. For black patients, 37 minutes. The silence in the room felt heavy. I didn't... David started, then stopped. I didn't consciously decide to make them wait longer. I know. That's what makes it insidious. Studies show this pattern across emergency departments nationwide. Black patients receive pain medication later, and in lower doses than white patients with identical presentations. Most of the doctors involved would be horrified to learn they're doing it. They're not consciously racist. They're just biased. David felt sick. How do I fix it? Same way you fix any bias. Awareness plus systems. Now that you know you have this tendency, you can watch for it. Better yet, you can implement a protocol. Everyone with chest pain gets pain medication within 15 minutes of admission, regardless of your assessment of their pain level or your gut feeling about whether they're exaggerating. Take my judgment out of it. Take your biased judgment out of it. Your clinical expertise is still valuable, but you have to build guardrails around it. Sarah leaned forward. Here's the thing, David. You're going to resist this. Your brain is going to tell you that you're not biased, that there must be another explanation for those numbers, that you treat all patients equally. That resistance is itself a bias. It's called bias blind spot, the tendency to see biases in others but not in yourself. David rubbed his face with both hands. This is exhausting. Yes, and it's necessary, because the alternative is continuing to provide worse care to black patients while telling yourself you're being objective. The next lecture focused on specific biases in more detail. Sarah walked them through case after case, each one illustrating a different cognitive trap. Anchoring bias. A patient's initial complaint shapes the entire diagnostic process, even when new information suggests a different direction. Availability heuristic. A doctor recently saw a rare disease, so now sees it everywhere, overestimating its probability. Sunk cost fallacy. Continuing an ineffective treatment because of the time and effort already invested in it. Dunning-Kruger effect. The least skilled practitioners are often the most confident, while experts recognize the limits of their knowledge. For each bias, Sarah provided not just examples, but strategies for mitigation, structured decision-making processes, devil's advocates, beige and updating, blind reviews, protocol-driven care. The key insight, Sarah said, is that you can't think your way out of cognitive biases through sheer willpower. Your brain will bias your thinking about your own biases. You need external structure, rules, checklists, other people, data systems that catch your errors. David found himself thinking about airplane crashes. Most modern crashes weren't caused by mechanical failure, but by human error, specifically by pilots being confident they were right when they were wrong. The aviation industry had responded by building elaborate systems to catch and correct human error, checklists, automated warnings, crew resource management training that explicitly address authority gradients and encourage co-pilots to challenge captains. Medicine, David realized, was about 30 years behind aviation in systematizing error prevention. A week later, David was reviewing cases with Dr. Martinez when he noticed something. "Linda, can I ask you something?" "About the Santiago case from last month." Linda looked up from her computer. "The 40-year-old with acute liver failure? What about it?" "You diagnosed autoimmune hepatitis pretty quickly. I'm looking at the chart, and I'm wondering, how did you rule out drug-induced liver injury so fast?" Linda frowned. "Patient denied any drug use." "Right, but we know patients don't always disclose everything, especially with herbal supplements or over-the-counter medications. Did we check her medicine cabinet? Interview family members?" "David, she said she wasn't taking anything." "I know, but I'm wondering if we anchored on her initial statement and didn't push hard enough." He pulled up the medication reconciliation form on his tablet. "Look, the admission nurse noted patient takes some vitamins but doesn't remember names. We never followed up on that." Linda was quiet for a moment. Then she pulled up the patient's current chart. "She's not responding to the autoimmune treatment as well as expected. What if we were wrong about the diagnosis? Then we've been treating the wrong condition for 3 weeks." Linda's expression shifted from defensive to thoughtful. "Okay, let's do a comprehensive medication history. Family interview, pharmacy records, everything." 2 days later, they had their answer. The patient had been taking a traditional Chinese herbal supplement that contained hepatotoxic compounds. Stopped the supplement, support liver function, and she improved dramatically. No immunosuppression needed. "I should have caught that," Linda said, reviewing the final report. "I took the patient's word without verification because it fit the narrative I'd already constructed." "We both did," David said. "I didn't question it either until Sarah's lecture on anchoring bias made me go back and review." Linda looked at him curiously. "This seminar you've been taking, it's really changed how you practice, hasn't it?" "It's changed how I think. About everything." That night, David sat with his journal, but instead of his usual 3-decision analysis, he wrote something different. "I've been thinking about what Sarah said, that recognizing bias is necessary, but not sufficient. That you can't just be aware of your biases and expect that awareness to fix them. You need systems. But I'm also realizing something else. The system itself can't be purely mechanical. It has to include other people. Because the biases that are hardest to see are the ones you're inside of, like a fish being asked to describe water. Brennan couldn't see his representative heuristic at work because he was inside it. I couldn't see my racial bias in pain management because I was inside it. Linda couldn't see her anchoring on the patient's initial statement because she was inside it, but other people could see it. I saw Brennan's error. Sarah saw mine. I saw Linda's. That's what makes this so hard and so important. Becoming a better thinker isn't just an individual project. It's necessarily social. You need other people to point out the shadows you cast that you can't see." He paused and added, "The scary thing is, how many shadows am I still casting that nobody's pointed out yet? How many biases am I operating under right now, in this moment, that I can't see?" The answer is, I don't know, and I can't know. That's the nature of bias blindness. All I can do is keep looking, keep questioning, keep asking others to check my thinking, keep building systems that catch my errors. It's humbling, It's uncomfortable. It's also the only honest way forward. The following week's lecture took an unexpected turn. Sarah began not with cases or concepts, but with a personal story. When I was 32, she said, I was part of a research team studying a new Alzheimer's drug. The preliminary results were promising, better than anything we'd seen before. I was excited. We all were. She advanced to a slide showing data tables. I was a statistician on the team, responsible for analyzing the results. And I found something troubling. A subset of patients showed cognitive decline on the drug. Not improvement, decline. About 15% of the sample. The room was perfectly quiet. I brought this to the principal investigator. He said the decline was within normal variation, probably just disease progression. He wanted to proceed with publication. I disagreed. We argued. Eventually, I was removed from the project. Sarah's voice remained steady, but David could see the tension in her shoulders. The paper was published without mentioning the subset with decline. The drug went to phase 3 trials. 18 months later, those trials were halted because of serious adverse events. The events were concentrated in patients with a specific genetic profile, the same subset I'd identified in our early data. She looked out at the audience. I tell you this not because I was heroic. I wasn't. I tell you because I was almost not heroic. I almost convinced myself the PI was right. I almost let my desire to be part of a breakthrough, my fear of conflict, my respect for authority. I almost let all of that override what the data was showing me. She clicked to a new slide. Motivated reasoning, the tendency to gather and interpret evidence in ways that support what we want to believe. This is perhaps the most dangerous bias of all, because it co-opts our intelligence. Smart people are better at motivated reasoning because they're better at constructing clever justifications for what they want to believe. Logic becomes the enemy of truth when it's deployed in service of a predetermined conclusion. David felt that sink in. How many times had he used his analytical skills not to find truth, but to defend his preferred answer? The antidote, Sarah continued, is not to stop wanting things. You can't eliminate motivation. The antidote is to build incentives for being right over being proven right, to reward people for finding errors, not just confirming hypotheses, to create psychological safety for dissent. She looked directly at David, and to develop the personal courage to say, I think we're wrong, even when it costs you something. After class, David approached Sarah. That story about the Alzheimer's drug, is that why you focus on critical thinking now? Partly. After that experience, I realized that being smart isn't enough. Being well-trained isn't enough. You also have to be intellectually honest, even when honesty is uncomfortable, especially then. She gathered her materials. And you have to recognize that your brain will actively work against your honesty. It will feed you rationalizations that feel like reasons. It will make you confident in conclusions you want to reach. How do you fight that? You don't fight it. You build structures around it. You make rules for yourself, like, I will actively seek evidence against my hypothesis, or I will consult someone who disagrees with me before finalizing my conclusion. You externalize your error checking. They walk toward the parking lot together. Sarah, can I ask you something personal? Go ahead. Do you ever get tired of it? Of constantly questioning yourself, checking for biases, second-guessing your thinking? Sarah was quiet for a moment. Yes, sometimes I do. Sometimes I wish I could just be certain about things, could trust my intuitions, could stop being vigilant. But then I remember the patients who would have been harmed if I'd stopped being vigilant, the research that would have been wrong, the decisions that would have been flawed. She unlocked her car. The price of clarity is constant effort, but the price of blindness is measured in consequences I'm not willing to pay. David watched her drive away, then stood in the parking lot for a long moment, thinking about shadows and lights, about blindness and sight, about the strange burden of knowing that you can't fully know yourself. His phone buzzed. A text from Rebecca. Coffee tomorrow? Want to talk about that case I mentioned. Think I might be experiencing confirmation bias, but not sure. David smiled and typed back, definitely. That's what friends are for, seeing each other's shadows. He got in his car and drove home through Boston streets, newly aware of all the biases that might be affecting his driving. Overconfidence in his abilities, optimism bias about accident likelihood, the fundamental attribution error when he judged other drivers. The awareness was exhausting. It was also, he was beginning to understand, a kind of freedom, because you couldn't correct errors you couldn't see. And now, at least, he was learning to see. Chapter 4. The Labyrinth. The conference room on the 8th floor of Boston generally smelled like stale coffee and frustration. 23 people, doctors, nurses, administrators, and IT specialists, had been meeting for 3 hours every Tuesday for the past 6 weeks, and they were no closer to solving the problem than when they'd started. The problem was simple to state. Hospital-acquired infections had increased by 40% over the past year. The solution, apparently, was impossible to find. David Okonkwo sat near the back, ostensibly there to take notes as a junior resident representative, but mostly watching the group dynamics with growing fascination. He'd learned enough from Sarah's lectures to recognize the patterns. People were proposing solutions without clearly defining the problem, advocating for their preferred approaches without examining alternatives, and talking past each other because they were solving different problems entirely. Dr. Richard Kelso, the hospital's chief medical officer, was growing visibly frustrated. Let's go through this one more time. Infection rates are up. We need to bring them down. What are we going to do? Improve hand hygiene compliance, said the infection control nurse. Increase environmental cleaning frequency, said the facilities manager. Better antibiotic stewardship, said the pharmacy director. Update the ventilation systems, said the head of building operations. They'd been through this exact same list 5 times. Each person had their domain, their expertise, their preferred solution. Nobody was wrong, exactly. But nobody was solving the problem either. David raised his hand. 23 pairs of eyes turned toward him with expressions ranging from curious to annoyed. Junior residents didn't usually speak up in these meetings. Can I ask a question? David said. Have we actually defined what problem we're trying to solve? Dr. Kelso frowned. We're trying to reduce hospital-acquired infections. Right, but that's the outcome we want. What's the actual problem causing the outcome we don't want? Silence. I mean, David continued, tried to articulate something he'd heard Sarah say. We're all proposing solutions, but it's like we're each solving a different problem. So maybe we need to step back and figure out what the actual problem is before we decide how to solve it. The facilities manager looked annoyed. The problem is obvious. Infection rates are up. That's a symptom, David said, not a root cause. If infection rates are up, something changed to cause that. What changed? More silence. Then the infection control nurse, Patricia Williams, spoke up. Actually, we haven't done that analysis. We've been so focused on implementing solutions that we never really investigated the underlying cause. Okay, Dr. Kelso said slowly. So how do we do that? David glanced toward the door, where Sarah Chen had just appeared. She'd been invited to observe the committee as part of a broader hospital initiative on decision-making quality. She caught his eye and nodded encouragingly. We could start by breaking down the problem systematically, David suggested. What changed in the past year? New procedures? Different patient populations? Staff changes? Physical plant modifications? Patricia pulled out her laptop. Give me a minute. Over the next 30 minutes, something shifted in the room. Instead of advocating for solutions, people started examining data. They pulled up infection reports, staffing records, procedural changes, patient demographics. And a pattern emerged. Wait, said Dr. Monica Patel, head of the ICU. Look at this. The infection rate spike started in March. What happened in March? We opened a new surgical wing, the facilities manager said. And we hired 15 new nurses to staff it, Patricia added. And we implemented the new electronic health record system. The IT director said quietly. Everyone looked at the IT director, the one that changed how we document hand hygiene compliance. Patricia asked. It didn't change whether we wash our hands. The IT director said defensively, just how we record it. But if documentation became harder or more time-consuming, David said, Thinking it through, people might skip the documentation. And if we're not documenting hand hygiene, we can't track compliance. And if we can't track compliance, we can't identify and correct lapses. Patricia was typing furiously. The old system had a simple button, one tap to confirm hand hygiene. The new system requires opening a menu, selecting an option, and confirming. It takes about 15 seconds, longer per patient encounter. 15 seconds doesn't sound like much, Dr. Kelso said. Times 20 patient encounters per shift, times 3 shifts per day, times however many staff we have. Monica calculated. That's a lot of cumulative time and cumulative friction. So people stopped documenting, Patricia said, which means we lost visibility into hand hygiene practices, which means we couldn't identify and correct compliance issues, which means infection rates went up. The room was quiet. The problem, David said slowly, wasn't hand hygiene itself. It was the system for monitoring hand hygiene. We created an invisible problem by making a documentation system that people wouldn't use. Dr. Kelso leaned back in his chair. So the solution isn't to improve hand hygiene, increase cleaning, change antibiotics, or upgrade ventilation. The solution is to fix the documentation system. It's part of the solution, Patricia corrected. We should still audit all those other areas. But yes, fixing the documentation system will probably have the biggest impact. Dr. Kelso looked at David. How did you know to ask that question? I didn't know, David admitted. I just learned that when you're stuck on a problem, it usually means you're solving the wrong problem. So you have to back up and figure out what you're actually trying to solve. After the meeting, Sarah walked with David toward the cafeteria. That was well done, she said. You helped him reframe the problem. I was just repeating what you taught us about problem decomposition and root cause analysis. Knowing the concept and applying it in a room full of frustrated stakeholders are different things. You had the courage to stop the momentum and ask a basic question. Sarah smiled slightly. Most people don't. They keep running faster in the wrong direction because stopping feels like admitting defeat. They got coffee and found a table in the corner. I've been thinking about what you said in the last lecture, David said, about how problem solving is really problem understanding. That most failures in problem solving come from solving the wrong problem or not understanding the problem well enough. It's true, we're taught to be solution-focused, to jump to answers quickly. That's rewarded in medical school, in residency, in practice. Fast diagnosis, fast treatment, fast resolution. Sarah stirred her coffee. But complex problems don't yield to speed. They yield to understanding. So, how do you develop that understanding? Systematically, I mean, Sarah pulled out a notebook and drew a diagram, a branching tree structure. There are several frameworks, but they all start with the same principle. Decompose a problem into its component parts. Break it down until you can see the structure clearly. She labeled different branches. What is the desired state? What is the current state? What's preventing movement from current to desired? What caused the current state? What constraints exist on potential solutions? It's like anatomy, David said, studying the diagram. You can't operate effectively if you don't understand the underlying structure. Exactly. And just like anatomy, problem structure isn't always obvious. You have to dissect carefully. Sarah added more branches to the diagram. Take the infection control problem. On the surface, it looked like a clinical practice issue. But when you decomposed it, looked at when it started, what changed, what systems were involved, you found it was actually a human factors issue embedded in a technology implementation. We never would have found that if we just implemented more hand hygiene training. No, you would have treated the symptom and missed the disease. Classic medical error, applied to organizational problems. Sarah looked at him thoughtfully. You're getting good at this. Have you thought about what you want to do after residency? David hadn't really. He'd been so focused on surviving residency that the future seemed distant and abstract. Why? Because the hospital is looking for someone to lead a new quality improvement initiative. Someone who understands clinical care, but also understands systems thinking and problem solving. Your name came up. Sarah, I'm still a resident. I barely know what I'm doing. You know more than you think. And more importantly, you know what you don't know. That's rarer than you'd expect. She finished her coffee. Think about it. But right now, let's talk about the next level of problem solving, generating solutions. That evening's lecture focused on creative problem-solving techniques. Sarah had invited a guest speaker, Dr. Elizabeth Hammond, a design thinking consultant who worked with hospitals and healthcare organizations. Traditional problem-solving in medicine is convergent, Elizabeth began. You gather symptoms, narrow down possibilities, converge on a diagnosis. It's like a funnel, wide at the top, narrow at the bottom. That works beautifully for diagnosis. She drew a funnel on the whiteboard, but it works terribly for complex organizational or systemic problems, because those problems don't have one right answer. They have multiple possible solutions, each with different trade-offs. For those problems, you need divergent thinking first, expanding possibilities, before you converge on a solution. She drew another diagram, a diamond shape wide in the middle. This is the double diamond model. First diamond, diverge to understand the problem fully, then converge on a problem definition. Second diamond, diverge to generate many possible solutions, then converge on the best one. David was taking notes frantically. This was the framework he'd been groping toward in the infection control meeting. Elizabeth continued. The hardest part for most people is staying in the divergent phase long enough. We want to solve problems, not explore them. We want answers, not questions. But premature convergence, jumping to solutions before you understand the problem or considering only one or two options, is the death of good problem solving. She clicked to a new slide showing a case study, a hospital emergency department with severe overcrowding. The administration had planned to expand the physical space, more rooms, more beds, more capacity. But when they actually studied the problem, Elizabeth said, they found the bottleneck wasn't the ED itself. It was hospital admissions. Patients were boarding in the ED for hours waiting for inpatient beds. So they implemented a rapid admission protocol and opened a short-stay observation unit. ED wait times dropped by 40% without adding any ED capacity. They solved a different problem than the one they initially thought they had, Rebecca said from front row. Exactly. And they only found the real problem because they forced themselves to explore before committing to solution. The lecture continued with exercises in divergent thinking, brainstorming techniques, lateral thinking puzzles, constraint removal exercises. David found it simultaneously exhilarating and frustrating. His instinct was to evaluate ideas as soon as they were generated, to sort them into good and bad piles. But Elizabeth kept pushing them to suspend judgment, to generate more ideas, to think wilder. The best solutions often sound ridiculous at first, she said. If you judge too quickly, you kill them before they can develop into something workable. 2 weeks later, David found himself leading a problem-solving session for a different hospital challenge. High readmission rates for heart failure patients. He'd been asked to facilitate because of his work on the infection control problem. He decided to apply Elizabeth's framework. Okay, he said to the assembled team of cardiologists, nurses, social workers, and case managers, we're not going to talk about solutions for the first hour. We're going to explore the problem. What do we actually know about why heart failure patients are readmitted? They mapped it out. Medication non-adherence, dietary non-compliance, missed follow-up appointments, inadequate social support, inability to recognize worsening symptoms, depression, and anxiety affecting self-care. Now, David said, let's go deeper on each of these. Why do patients not take their medications? The answers came: too expensive, too complicated, side effects, don't understand what they're for, forget to take them, run out before follow-up appointment. Why don't they make follow-up appointments? They don't know how to. Transportation barriers, work conflicts, anxiety about medical settings. Think they're fine. By the end of the first hour, they had a complex map of interconnected causes. The problem wasn't patients don't follow instructions. The problem was a web of medical, social, psychological, and systemic factors. Now we can generate solutions, David said. But here's the rule. For the next 30 minutes, no judging. Every idea gets written down. Quantity over quality. Wild ideas welcome. They generated 47 potential solutions, ranging from practical, medication reminder app, to ambitious, home health monitoring devices, to seemingly absurd, adopt a patient program where medical students provide companionship and support. Then came the hard part, convergence, evaluating which solutions would have the biggest impact, which were feasible with available resources, which could be implemented quickly versus long-term. They ended up with a multi-pronged approach, a pharmacist-led medication reconciliation and education program, a nurse navigator to coordinate follow-up care, a partnership with community organization to address transportation barriers, and, surprisingly, a pilot version of the Adopt a Patient idea, reframed as a peer support program matching recover heart failure patients with newly diagnosed ones. I don't know if this will work, Dr. Sarah Washington, the senior cardiologist, said as the meeting ended, but it's the first time I feel like we're actually addressing the real problem instead of just treating symptoms. That night, David met Sarah at their usual coffee shop. He told her about the session. "You're developing an important skill," Sarah said, "the ability to hold complexity without collapsing it prematurely. Most people can't tolerate the discomfort of not knowing the answer, so they grab the first solution that seems plausible and declare the problem solved." "It is uncomfortable," David admitted. "During that meeting, there were several times when I wanted to just pick something and move on, stay in exploration mode, keeping options open. It takes discipline. It's like surgery. You have to open before you can repair. But our instinct is to close as quickly as possible." Sarah smiled. "The problem is, if you close too fast, you miss things. You operate on the wrong spot. You solve the wrong problem." David thought about all the cases he'd seen where that had happened. Treating symptoms instead of underlying conditions. Addressing proximate causes while ignoring root causes. Implementing solutions that made things worse because they didn't actually fit the problem. "Sarah, can I ask you something? About your mother?" Sarah's expression grew more guarded, but she nodded. "You said she has early onset Alzheimer's. You're a neurologist who specializes in cognitive decline. Have you ever... do you approach her care the same way you approach hospital problems? With all the systematic analysis?" Sarah was quiet for a long moment. "No, and yes. I tried it first. I read every paper, analyzed every treatment option, mapped out every possible intervention. I was going to solve this problem through sheer intellectual force. But Alzheimer's isn't a problem to be solved. It's a condition to be managed and a loss to be grieved. The systematic analysis helped with treatment decisions. That's how we got her into the right clinical trial. But it didn't help with the fundamental reality. I'm losing my mother piece by piece, and no amount of problem solving will change that." David didn't know what to say. "Here's what I learned," Sarah continued. "Problem-solving skills are powerful, but you have to know when you're facing a solvable problem versus an unsolvable situation. Some things can be fixed. Some can only be endured. The wisdom is knowing which is which." She looked down at her coffee cup. "My mother taught me critical thinking. She taught me to ask hard questions, to challenge assumptions, to never accept easy answers. Now she can't remember teaching me any of that, but I still have the skills. That's something." David thought about the labyrinth of problem-solving they'd been exploring, the ways problems could be decomposed, analyzed, solved, but some mazes had no exit. Some problems had no solution, only responses. "I'm sorry," he said. "Don't be grateful you learned these skills while you still can, because the sharpest mind in the world still hits problems it can't solve. What matters then is having the wisdom to know it, the grace to accept it, and the courage to keep trying anyway." The following week, Sarah's lecture took an unexpected turn. Instead of teaching, she posed a problem to the class. "A hospital has a limited budget," she said. "They can either invest in a new neonatal intensive care unit that will save an estimated 10 infant lives per year, or they can invest in a community health program that will prevent an estimated 30 deaths per year from diabetes and heart disease through better screening and intervention. What should they do?" The room erupted in discussion. Some argued for the NICU. Infant lives were more valuable, more years of life saved. Others argued for the community program. More total lives saved, plus preventive care, was more cost-effective. Sarah let them debate for 20 minutes, then held up her hand. Notice what you're doing. You're all trying to solve the problem. But has anyone questioned whether it's the right problem? Silence. Why does the hospital only have budget for one? Who decided those were the only two options? What assumptions are we making about how healthcare resources should be allocated? What values are implicit in the way the problem is framed? David felt something click. The problem, as stated, isn't a problem to be solved. It's a false dilemma that forces a choice between two goods when the real problem might be inadequate healthcare funding or inefficient resource allocation, or a system that makes hospitals compete for limited resources instead of addressing community health holistically. Yes, Sarah said. Sometimes the most important problem-solving skill is recognizing when you're being asked to solve the wrong problem, when the problem framing itself contains assumptions that need to be challenged. She wrote on the board, "Before you solve a problem, question whether it's the right problem." This is especially important in healthcare because the problems we're asked to solve often reflect power structures, resource allocation systems, and value judgments that we've internalized so deeply we don't even see them anymore. The patients who slip through gaps in care, the populations we systematically underserve, the ways we prioritize some lives over others, these aren't natural facts. They're problems we've collectively decided not to see or not to solve. The room was very quiet. So yes, learn problem-solving skills. Master the techniques of analysis and creative thinking, but also develop the moral imagination to see which problems we're being asked to solve, which we're being asked to ignore, and which we're being prevented from even recognizing as problems. That night, David sat with his journal, but instead of his usual entries, he drew a map, a labyrinth. At the center, he wrote, "The right problem." Around it, he drew the pathways he'd learned. Decomposition, root cause analysis, divergent thinking, convergent thinking, constraint analysis, systems thinking. But he also drew the dead ends, premature convergence, false dilemmas, treating symptoms instead of causes, solving the wrong problem, accepting problem frames uncritically. At the entrance to the labyrinth, he wrote, "Most people never make it to the center. They get lost in the entrance, solving problems that don't matter, ignoring problems that do." Then he wrote, "The art of problem solving is also the art of problem finding. You can't solve what you can't see." He thought about Sarah's mother, about the infection control problem, about the readmission rates, about the impossible choice between the NICU and the community health program. Some problems yielded to analysis. Some required creativity. Some needed to be reframed entirely. And some, the hardest lesson, weren't problems to be solved but realities to be faced. The wisdom was knowing which was which. David closed his journal and looked out the window at the lights of Boston. Somewhere in this city, problems were being solved and problems were being missed. Symptoms were being treated while causes were being ignored. False dilemmas were being accepted while real questions went unasked. And somewhere, Sarah Chen was sitting with her mother, who was forgetting how to remember, facing a problem that had no solution but required all the wisdom and grace and love that Sarah could summon. The labyrinth had no exit, but you could still find your way to the center, to the heart of things, to the truth of what actually mattered. That was something. That was everything. Tomorrow, David would try again, would ask better questions, see more clearly, think more deeply. Tonight, he simply sat with what he'd learned. That the art of solving problems began with the courage to see them clearly, to question them fully, and to admit when you were lost so you could find your way again. The path through the labyrinth was long, but at least now he could see it. Chapter 5, The Anatomy of Truth. The paper sat on David Okonkwo's desk like an accusation. Novel biomarker shows promise in early cancer detection, read the headline from a medical journal. The study claimed a 94% accuracy rate. The authors were from a prestigious university. The journal had a high impact factor. Everything about it screamed legitimate, except David didn't believe it. He couldn't articulate exactly why. Just a nagging feeling that something was off. The certainty was too clean, the results too good, the conclusions too sweeping. It reminded him of Sarah's warning about things that seemed too obvious, too perfect. He pulled up his laptop and started digging. 3 hours later, Rebecca Torres found him still at his desk, surrounded by printed papers and open browser tabs, muttering to himself. "You okay?" she asked. David looked up, his eyes slightly wild. "This study is garbage." "Which study?" "The biomarker one. Everyone's citing it, talking about how it's going to revolutionize early cancer detection. But look," he gestured at his screen. "Sample size of 43 patients. Controls weren't properly matched. They tested 17 different biomarkers and only reported the one that showed positive results. They didn't adjust for multiple comparisons. They didn't have external validation. And this is the kicker. The study was funded by the company that makes the test." Rebecca pulled up a chair. "How did you find all that?" "I started asking the questions Sarah taught us. Who conducted the study? How was it designed? What did they actually measure? What didn't they tell us? What would a critic say?" David pulled up another tab. "And then I started looking for what they didn't include in the paper. The registered clinical trial protocol shows they plan to measure 32 outcomes. They only reported 5. That's selective reporting. So it's fraudulent? Not necessarily. Could be researcher bias. They genuinely believe in their biomarker, so they unconsciously design and report the study in ways that support it. Could be publication bias. Journals prefer positive results, so they emphasize the positive findings. Could be p-hacking. They tried multiple analyses until they found something statistically significant." David rubbed his eyes. "Or it could be deliberate fraud. Hard to know without more information. But everyone's treating it as gospel because most people don't read past the abstract. They see prestigious journal, university researchers, 94% accuracy, and they accept it." David turned back to his screen. "That's what Sarah's lecture tonight is about. How to dissect arguments and evaluate evidence. How to tell the difference between what sounds true and what is true." The lecture hall was packed. Word spread about Sarah Chen's seminars, and they'd outgrown the original room. Sarah stood at the front, looking out at nearly 100 people. "Information is the oxygen of modern life," she began. "We breathe it constantly, often without noticing. And just like oxygen, it can sustain us or poison us, depending on its quality." She clicked to a slide showing 3 headlines about the same study, each from a different news outlet. The headlines told radically different stories. Same study, 3 different interpretations. One says the drug is a breakthrough. One says it shows modest benefits. One says it's no better than existing treatments. Sarah paused. "Which one is true?" "All of them," someone ventured. "Exactly. And none of them. Because truth isn't just about facts. It's about context, interpretation, emphasis, and framing. A true statement can still be misleading if it omits crucial context." She advanced to the next slide, a framework for evaluating information. "When you encounter a claim, especially an important one, you need to perform what I call an evidential autopsy. You dissect the argument layer by layer, examining its anatomy, source, methodology, evidence quality, logical structure, potential biases, alternative explanations." David was taking notes, but he already knew this pattern. It was what he'd done with the biomarker study. Sarah walked through examples. A news article about a drug trial that failed to mention the trial was stopped early for safety concerns. A study claiming a dietary supplement improved cognitive function that was conducted by the supplement manufacturer. A politician's speech that used accurate statistics to support a misleading conclusion. "The hardest part," Sarah said, "isn't identifying obviously false information. It's identifying sophisticated misinformation, claims that are technically true but fundamentally misleading, or claims made by credible people that rest on flawed reasoning, or studies that look rigorous but have subtle methodological problems that invalidate their conclusions." She pulled up a new slide, Tolman's model of argument. Stephen Tolman was a British philosopher who developed a framework for analyzing arguments. It has 6 components: claim, data, warrant, backing, qualifier, and rebuttal. She drew a diagram connecting them. Most arguments you encounter in daily life are missing several of these components. Learning to spot what's missing helps you evaluate the argument's strength. For the next hour, Sarah walked them through increasingly complex examples. A legal argument about medical malpractice, a scientific debate about climate change interventions, a policy proposal about healthcare reform. Each one was dissected using Tolman's framework, revealing hidden assumptions, unsupported leaps, and missing evidence. The goal isn't to become cynical, Sarah said as the lecture wound down. It's to become discerning, to develop what I call an intellectual immune system, the ability to identify and neutralize bad information before it infects your thinking. After the lecture, a small group gathered at the coffee shop. David told them about the biomarker study. "I want to write something about it," he said. "A letter to the journal, maybe, or a blog post. Point out the methodological problems." "Be careful," warned Thomas Park. "You're a resident. They're established researchers. You could look like you're just trying to make a name for yourself by tearing down others." David had worried about the same thing. But if the study is flawed and people are making clinical decisions based on it, then you have a responsibility to speak up, Rebecca finished, even if it's uncomfortable. James Patterson, the radiologist, leaned forward. "Here's what you do. Document everything. Make your critique about the methodology, not the people. Cite specific problems with specific evidence. Use neutral language. The study appears to have limitations rather than 'this study is garbage.' And before you publish anything, have someone senior review it." "I could send it to Sarah," David said. "Do that. But also, are you prepared for blowback? Academic medicine can be petty. People who feel criticized can make life difficult for critics." David thought about Sarah's story of being removed from the Alzheimer's research team, about the cost of intellectual honesty. "I'm prepared," he said. He spent the next week crafting his critique. He read everything he could find about the biomarker, about the researchers, about similar studies. He constructed his argument carefully. Here's what the study claims. Here's what the evidence actually shows. Here are the specific methodological concerns. Here are alternative explanations for the results. He sent it to Sarah. She returned it 3 days later covered in comments. Not criticisms. Exactly, more like surgical improvements. Tightening arguments. Removing emotional language. Adding citations. Anticipating counterarguments. They met in her office to discuss it. "This is good work," Sarah said. "Rigorous, fair, important. But before you publish it, I want you to do one more thing." "What?" "Steel man the study. Write the strongest possible defense of it you can. Really try to argue that it's methodologically sound and the conclusions are justified." David frowned. "Why would I do that?" "Because if you can't make a strong case of the study, you don't understand it well enough to critique it. And if you can make a strong case for it, you'll better understand its actual weaknesses. Not the straw man weaknesses, but the real ones." It took David another week. Writing a defense of the study forced him to see its strengths. There were some clever design elements. The hypothesis was plausible. The biomarker mechanism made biological sense. But the exercise also clarified where the study truly failed. Not in its hypothesis or design, but in its execution, analysis, and interpretation. His final critique was shorter, sharper, and more devastating than his first draft, because now he understood exactly what was wrong and could articulate it precisely. Sarah read the revision and nodded. "This is ready. I'll send it to a colleague at the journal who handles methodological critiques. It might not get published, but at least it will be on record. And if it does get published, then you've done something important. You've improved the quality of medical knowledge. That's the whole point." 2 months later, David's letter was published. The response was immediate and polarized. Some researchers thanked him for the careful analysis. Others accused him of nitpicking, of holding studies to impossible standards, of being a glory-seeking resident trying to tear down his betters. The original study authors published a defensive reply that didn't address most of David's concerns, but they also announced they were conducting a larger, properly controlled validation study. "That's the real victory," Sarah said when they discussed it. Not the publication, not the debate, the fact that they're going to do better science. David wasn't so sure it felt like victory. The personal attacks had stung. Several senior physicians had privately warned him about making enemies so early in his career. He'd started to wonder if speaking up had been worth it. Then a medical student approached him after rounds. "Dr. Okonkwo, I just want to say thank you. I read your letter about the biomarker study. I'm doing my thesis on diagnostic tests, and I was planning to cite that study until I read your analysis. You taught me to look more carefully at methodology. David realized this was a point. Not winning arguments, not being right, not even getting published. Teaching others to think more carefully, improving the collective quality of reasoning. Sarah's next lecture focused on a different aspect of information evaluation, the problem of expertise. We can't personally verify everything we believe, she began. Life is too short, knowledge is too vast. So we rely on experts. The question is, how we know which experts to trust. She clicked to a slide showing 5 people, all with impressive credentials, making contradictory claims about the same topic. Expertise is real. Some people genuinely know more than others. But expertise is also weaponized. People use credentials to lend authority to claims that may not deserve it. And expertise is domain-specific. Being brilliant in one field doesn't make you reliable in another. She walked through warning signs. Experts who claim certainty where uncertainty exists. Experts whose conclusions consistently align with their financial interests. Experts who dismiss legitimate criticism as ignorance. Experts who make claims outside their actual domain of expertise. But here's the paradox, Sarah said. To evaluate experts, you need expertise. To know if a claim is reasonable, you need to understand the field. So what do you do when you lack the expertise to evaluate the expert? David found himself wondering the same thing. How had he known the biomarker study was flawed? He wasn't an expert in biomarkers or cancer detection, yet something had told him to look closer. Sarah provided an answer. You look at the structure of the argument rather than the content. You ask, is this person making claims that can be tested? Are they open to criticism? Do they acknowledge uncertainty? Do other experts in the field disagree? Have they changed their mind when presented with new evidence? She told a story about the physicist Richard Feynman, who developed a simple test for whether someone understood a topic, asked them to explain it in simple terms without jargon. If they can't explain it simply, they probably don't understand it deeply. Deep understanding produces clarity, not obscurity. That principle came up again in David's own work. He was presenting a case at Grand Rounds, a complex patient with multiple systems involved. He prepared a detailed technical presentation with lots of medical terminology. Dr. Martinez stopped him halfway through. David, pretend I'm the patient's family member. Explain it to me in plain English. David tried and discovered he couldn't. He'd learned the terminology, memorized the pathophysiology, but he hadn't actually understood the case well enough to explain it simply. That's your homework, Martinez said. Understand it well enough to make it simple. If you can't explain it to a smart non-expert, you don't understand it well enough to make good decisions about it. David spent the evening reconstructing his understanding from the ground up, not memorizing facts, but understanding relationships, not citing literature, but grasping mechanisms. By the time he could explain the case in simple terms, he understood it much better and realized his initial treatment plan had been missing something important. He called the attending covering the patient and suggested a modification to the treatment. The attending agreed. The patient improved. Understanding, David realized, wasn't about accumulating information. It was about building clear mental models that could generate explanations, predictions, and decisions. One evening, David found himself at a dinner party hosted by Jake's company. He was making small talk with a data scientist named Rachel when the conversation turned to news and media. I don't trust anything anymore, Rachel said, gesturing with her wine glass. Everyone has an agenda. The news is biased. Studies contradict each other. How are we supposed to know what's true? It was a question David heard often. Usually, he didn't have a good answer. Tonight, fortified by months of Sarah's teaching, he tried. I think trust is the wrong framework, he said. It's too binary. Either you trust something or you don't. Better to think in terms of confidence levels and provisional beliefs. Like, given what I currently know and the quality of the sources and my understanding of potential biases, I'm 60% confident this claim is accurate. Rachel looked skeptical. That's a lot of work for every piece of information. Not every piece. Most information doesn't matter. You can just note it and move on. But for things that will affect your decisions or beliefs, yeah, it's worth the work. David thought about how to explain this clearly. Think of it like food safety. Most of the time, you trust that restaurant food is safe. But if something seems off, weird smell, unusual texture, you examine it more carefully. Same with information. Most of the time, quick evaluation is fine. But when the stakes are high or something seems off, you dig deeper. And what makes something seem off? Lots of things. Claims that seem too good to be true. Arguments that rely heavily on emotional manipulation. Sources that benefit from you believing the claim. Absence of nuance in complex topics. Certainty where there should be uncertainty. David smiled slightly. I'm learning that skepticism isn't cynicism. It's just careful attention. Rachel considered this. So, how do you evaluate news sources? Which ones do you trust? I don't trust sources. I evaluate specific claims. Good sources can publish bad stories. Bad sources can occasionally get things right. What matters is whether a specific claim is well supported, not whether it comes from a source I generally like. They talked for another hour, and David found himself enjoying the challenge of translating Sarah's frameworks into conversational language. Rachel asked good questions, pushed back on weak points, made him clarify his thinking. As he drove home that night, David realized something. Teaching critical thinking was making him better at critical thinking. Having to explain concepts forced him to understand them more deeply. Defending ideas against skepticism forced him to examine whether they were actually defensible. Maybe that was Sarah's secret. She'd been teaching critical thinking for years, not just to help her students, but to keep her own thinking sharp. The semester's final lecture approached. Sarah had asked David to co-present, to talk about his experience applying critical thinking in medical practice. He was nervous but excited. He prepared carefully, thinking about what had actually changed in his thinking over the past months. Not just the specific techniques he'd learned, but the fundamental shift in how he approached information and arguments. The night of the lecture, he stood next to Sarah in front of 100 people and told them about the biomarker study, the ethics committee meeting, the case presentations, the dinner party conversation. Here's what I've learned, he said. Information isn't just data. It's an argument. Every news article, every study, every expert opinion is making an implicit argument. You should believe this. And before you accept that argument, you have the right, maybe the obligation, to ask, why should I believe this? What's the evidence? What are the alternative explanations? What am I not being told? He clicked to his next slide, a flowchart he developed for evaluating medical information. It starts with, what's the claim? Then, what's the evidence? Then, how strong is that evidence? Then, what are the biases or conflict of interest? Then, what do credible critics say? Then, what would change my mind? He walked through examples from his own practice. Cases where careful evaluation had changed his conclusions. Studies he'd almost cited before realizing they were flawed. Arguments he'd almost accepted before examining their structure. The goal isn't perfection, he concluded. I still make mistakes. I still accept bad arguments sometimes, miss important details. Let biases influence my thinking. But I catch myself more often now. I pause more, question more, think more carefully about what I'm accepting as true. And when I do get it wrong, which I will, I'm more likely to notice and correct it, because I'm paying attention not just to what I think, but to how I think. The room was quiet when he finished. Then someone started clapping, and others joined in. After the lecture, several people thanked him. A few asked for copies of his flowchart. One medical student said he wanted to write his thesis on information evaluation in clinical practice. Sarah pulled him aside as the room cleared. That was excellent, she said. You've come a long way from the resident who questioned himself out of diagnosing appendicitis. I'm still that person, David said, just more aware of my own thinking now. That's all critical thinking is. Awareness plus tools plus practice. Sarah smiled. You're ready for the next phase. Which is, everything we've learned so far has been preparation. Now we talk about what makes it hardest. Other people. David felt a flicker of apprehension. Other people meant politics, relationships, difficult conversations. conflicting values. It meant applying critical thinking not to impersonal questions of evidence and logic, but to messy human interactions where emotions ran high and stakes were personal. "I'm not sure I'm ready for that," he admitted. "Nobody ever is," Sarah said. "But that's where critical thinking matters most. Because the hardest truths to see are the ones that cost us something to acknowledge. And the hardest thinking to do is the thinking that might change important relationships or challenge group identities." She gathered her materials. "See you next week. We're talking about diverse perspectives and intellectual humility. Bring your discomfort. You're going to need it." David walked to his car through the cooling Boston evening, thinking about truth and arguments and the anatomy of information, thinking about how much easier it was to dissect a study than to dissect a conversation, to evaluate evidence than to evaluate your own certainties. The real test, he suspected, was just beginning, but at least now he had tools. At least now he could see. That would have to be enough. Chapter 6. Voices in the Room. The hospital's ethics committee meeting had been going for 90 minutes, and the temperature, both literal and metaphorical, was rising. Dr. Robert Chen, a senior oncologist, had just finished presenting a case that divided the room almost perfectly in half. The patient was a 17-year-old named Marcus Thompson with osteosarcoma. Standard treatment would involve amputation of his leg, followed by chemotherapy. Marcus was refusing the amputation. His parents supported the refusal, wanted to try alternative treatments first. The oncology team believed this delay would likely kill him. "The medical facts are clear," Dr. Chen said, his voice tight with frustration. "Without amputation, his survival rate drops from 70% to less than 20%. This isn't a close call, it's life or death." "The ethical facts are also clear," countered Dr. Patricia Williams, a palliative care specialist. "A nearly adult patient has the right to refuse treatment, especially treatment that will permanently disable him. We don't amputate people against their will." David Okonkwo, attending his first ethics committee meeting, watched the two physicians talk past each other. They weren't really arguing. They were speaking from different value systems without acknowledging that's what they were doing. Sarah Chen, no relation to Dr. Robert Chen, was also in the room, observing as part of her consulting work with the hospital. She caught David's eye and gave him a subtle nod, a signal he'd learned meant, "Pay attention to what's happening here." "Maybe we should vote," suggested the committee chair, looking weary. "No," David heard himself say. Everyone turned to look at him. "I mean, shouldn't we understand each other's positions before we vote?" "We understand perfectly," Dr. Chen said. "I want to save his life. She wants to let him die." "That's not what I want," Patricia protested. "Then what do you want?" David asked, genuinely curious. Patricia paused, seeming to collect her thoughts. "I want Marcus to have agency over his own body. I want his values and fears and hopes to matter as much as our medical protocols. I want us to acknowledge that survival isn't the only relevant outcome. Quality of life matters too. And I want us to explore whether there's a way to respect his autonomy while still giving him the best possible chance." "And you?" David asked Dr. Chen. Chen was quiet for a moment. "I want to not watch another teenager die from a curable disease because we prioritize philosophy over medicine. I want his parents to not lose their son. I want Marcus to have a chance to grow up, even if growing up means growing up with one leg." The room was silent. Then Sarah spoke. "What I'm hearing is that you both want Marcus to live. You both care about his well-being. You're not actually disagreeing about values. You're disagreeing about how to balance competing values in an impossible situation." She stood and walked to a whiteboard. "Let's map this out. What are the values everyone agrees on?" Over the next 30 minutes, something remarkable happened. Instead of arguing positions, they articulated shared values: preserving life, respecting autonomy, minimizing suffering, supporting family relationships, maintaining trust between patients and doctors. Then they examined where those values came into conflict in this specific case. By the end, they hadn't resolved the dilemma. There was no easy resolution. But they had transformed the conversation from adversarial to collaborative. They agreed to bring in a psychiatrist to evaluate Marcus's decision-making capacity, to consult with patients who'd undergone similar procedures, to explore whether a brief trial of less invasive treatment could be ethically justified while still preserving future options. After the meeting, Sarah pulled David aside. That was well done. You defused the conflict by asking people to actually listen to each other. I just didn't want to watch them fight. Fighting is easy. Understanding is hard, especially when people have fundamentally different worldviews. Sarah gathered her materials. That's what tonight's lecture is about. How to engage with perspectives that genuinely contradict your own without either dismissing them or abandoning your own position. That evening's lecture hall felt different. Sarah had rearranged the chairs into small groups rather than lecture hall rows. People shifted uncomfortably in the unfamiliar configuration. We're going to do something different tonight, Sarah announced. We're going to disagree with each other. On purpose. Productively. She distributed cards with controversial statements. Physician-assisted suicide should be legal. Healthcare is a right, not a privilege. Alternative medicine should not be covered by insurance. Medical decisions for minors should ultimately rest with parents. Find someone who disagrees with you, Sarah instructed. Your job isn't to convince them. It's to understand why they believe what they believe well enough that you could argue their position convincingly. David found himself paired with James Patterson, the radiologist. Their topic: medical error should be treated as criminal negligence. I assume you're against that, James said, given that you're a resident who's probably made dozens of errors already. David bristled, then caught himself. This was a test. Could he engage with a challenging perspective without getting defensive? I am against it, David said carefully. Not because I want to protect bad doctors, but because I think criminalizing error would make medicine less safe. Doctors would hide mistakes instead of reporting them. We'd lose the transparency. We need to learn from errors. But what about accountability? James countered. If a pilot can be prosecuted for negligence that kills passengers, why not a doctor who kills patients through carelessness? They debated for 20 minutes. David found himself having to really think about why he believed what he believed. James pushed on weak points in his reasoning, made him confront uncomfortable truths about medical culture. Then Sarah called time and asked him to switch. Now they had to argue the opposite position. David, now arguing for criminalizing medical error, discovered something unsettling. There were good reasons for that position. The lack of accountability in medicine was real. The way the system protected incompetent doctors was real. His own initial certainties started to crack. When the exercise ended, Sarah brought everyone back together. What did you learn? That people who disagree with me aren't idiots, someone said, getting a laugh. That my position has weaknesses I hadn't noticed, another person added. That understanding someone's reasoning doesn't mean agreeing with their conclusion, David said. I understand James's position better now. I still disagree with it, but I get why a reasonable person would believe it. Sarah nodded. That's intellectual empathy, the ability to inhabit a perspective different from your own. It's different from agreement and different from sympathy. It's the recognition that intelligent, well-meaning people can look at the same facts and reach different conclusions because they weight values differently or bring different background assumptions. She wrote on the board, strong opinions weakly held. This phrase, coined by Stanford professor Paul Sappho, captures something important. You can have convictions. You should have convictions, but hold them provisionally. Be willing to change your mind when presented with better evidence or better reasoning. The opposite, weak opinions, strongly held, is much worse, believing things without good reason and clinging to those beliefs regardless of evidence. The following week, David attended a departmental meeting where physicians were discussing a proposed policy change, mandatory reporting of colleagues' minor protocol violations. The debate was heated. One camp argued that safety culture required reporting everything. The other camp argued that this would create a toxic environment of surveillance and punishment. David listened for patterns. Both sides were making valid points. Both sides were also talking past each other, assuming bad faith, constructing straw man versions of the opposing view. Finally, he raised his hand. Can I try something? Can we take 10 minutes where people from each side try to articulate the strongest version of the opposing argument? There was skepticism, but the department chair agreed. Dr. Martinez, who favored mandatory reporting, stood up. The strongest argument against mandatory reporting is that it confuses safety with compliance. True safety culture comes from psychological safety, people feeling comfortable admitting and learning from mistakes. If we create a climate of fear where every minor deviation gets reported, people will hide their mistakes instead of learning from them. We'll have perfect compliance records and terrible actual safety because all the errors will go underground. There was a pause. Then Dr. Williams, who opposed mandatory reporting, stood. The strongest argument for mandatory reporting is that informal, discretionary reporting creates a two-tier system. Well-liked doctors get second chances. Less popular doctors get reported. The system becomes about politics rather than safety. Mandatory reporting removes that discretion, ensuring everyone is held to the same standard. It's not about punishment. It's about equity and accountability. The room's energy changed. People started actually listening to each other instead of preparing their rebuttals. They ended up crafting a compromise. Mandatory reporting for serious violations, discretionary reporting with clear guidelines for minor ones, and robust protection for people who self-report errors. After the meeting, Dr. Martinez approached David. That steel manning exercise, where'd you learn that? Sarah Chen's seminar on critical thinking. I should take that seminar. I'm tired of meetings where everyone just yells past each other. Martinez paused. You know what the hardest part is? Actually wanting to understand the other side. It's so much easier to just think they're wrong or stupid or corrupt. Yeah, David agreed. Understanding is harder than dismissing. And it's risky. You might realize they have a point. The risk of understanding became personal for David a few weeks later. He was having dinner with his family, his parents, his older sister Chioma, and his younger brother Emeka. The conversation turned to politics, then to healthcare policy, then to a bitter argument between David and his father. His father, a small business owner, was furious about proposed healthcare regulations that would increase his costs. David, thinking about patients who couldn't afford care, argued that businesses needed to do more to support healthcare access. You think I don't care about sick people? His father said, his voice rising. I work 70 hours a week to provide for this family and employ 15 people. Now you want to tell me I should pay more so you can feel good about your politics. It's not about my politics, Dad. It's about people dying because they can't afford insulin. And what about people losing jobs because small businesses can't afford new regulations? Do those people not matter? They were shouting now. Chioma tried to intervene, but David was too angry to stop. His father was being selfish. Couldn't he see that? Emeka, quiet until now, spoke up. David, do you actually understand Dad's business? Like the actual numbers? What? His profit margin last year was 6%. He pays health insurance for all his employees already. That's 32% of his labor costs. If the new regulations add another 5%, he'll either have to lay people off or go out of business. David stopped. He'd been arguing from principles without understanding the practical reality his father faced. I didn't know that, he said quietly. You didn't ask, his father replied. The dinner ended uncomfortably. David left feeling rattled. He'd been so certain his position was right, his father's wrong. Now he wasn't sure what he thought. He called Sarah the next morning. I failed your test, he told her, explaining the dinner argument. What test? Engaging with diverse perspectives. Understanding instead of dismissing. I just yelled at my dad like he was an idiot. So you failed once. What did you learn? David thought about it. That understanding someone's perspective requires curiosity about their actual situation, not just their stated position. That I'm much worse at intellectual empathy when it's personal. That I was so attached to being right that I didn't stop to consider I might be wrong. Those are valuable lessons. What are you going to do about it? Apologize. Ask my dad to explain his business to me. Actually listen instead of just waiting to argue. Good. And David? This never gets easy. The closer something is to your identity or values, the harder it is to engage with opposing views charitably. Recognizing that difficulty is the first step. David spent the next evening with his father, asking questions about the business. How many employees? What were the actual costs? What were the margins? What happened during the 2008 recession? How did he make decisions about healthcare coverage? His father, surprised by David's genuine interest, opened up. He talked about the employees he'd had to lay off during hard times, the families who depended on their paychecks, the impossible choices between paying for healthcare and making payroll. I want everyone to have healthcare, his father said, but I also have to keep 15 people employed. When you're in medical school talking about policy, those aren't real people to you. To me, they're Tony and Maria and James. They have kids. They have mortgages. I can't just shrug and say, well, the greater good requires me to fire you. David felt something shift. His position on healthcare policy hadn't changed. He still thought universal coverage was morally right, but his understanding of the trade-offs became more complex, more nuanced, more uncomfortable. I'm sorry, I yelled. David said, I was treating you like an abstraction, business owner who opposes healthcare reform. I wasn't thinking about you as a person facing impossible choices. His father smiled slightly. I did the same to you. Treated you like naive idealist doctor who doesn't understand the real world. Your mother would say we're both stubborn. She'd be right. They talked for 2 more hours. They didn't resolve their policy disagreements, but they understood each other better. And David realized that was actually harder than resolution. Resolution lets you stop thinking. Understanding required you to keep thinking, keep holding complexity, keep acknowledging that people you disagreed with had valid concerns. Sarah's next lecture built on these themes. Intellectual humility, she began, is a recognition that you might be wrong, that your knowledge is limited, that your perspective is partial, that your conclusions are provisional. She clicked to a slide showing the Dunning-Kruger effect, the tendency for people with low expertise to overestimate their competence, while experts recognize the limits of their knowledge. True expertise makes you less certain, not more, because the more you know about a subject, the more you understand its complexity, its ambiguities, its open questions. She paused. But our culture rewards certainty. Confident people get elected, get promoted, get listened to. Humble people seem weak or indecisive. David thought about his argument with his father. He'd been so certain. That certainty had made him feel righteous, strong, clear. But it had also made him wrong. Not wrong about the principle, but wrong about the situation's complexity. So, how do you maintain convictions while staying intellectually humble? Someone asked. By distinguishing between your values and your beliefs about the world, Sarah said. Your values, what you think matters, what you think is right, can be strongly held. But your beliefs about facts, about how the world works, about what policies will achieve your values, those should be held more loosely. Those should be constantly tested against reality. She told a story about changing her mind on an important question in her field. How uncomfortable it was. How she'd resisted at first. How finally accepting she'd been wrong had been both humbling and liberating. Changing your mind based on evidence isn't weakness, Sarah said. It's strength. It means you care more about being right than about having been right. More about truth than about ego. Rebecca raised her hand. But what if changing your mind means losing your community? I've seen people ostracized for changing their position on contentious issues. Intellectual humility has social costs. Yes, Sarah acknowledged. That's why it takes courage. Intellectual humility isn't just a cognitive skill. It's a moral practice. It requires you to value truth over belonging, understanding over tribal loyalty, growth over consistency. David found himself thinking about tribes and belonging a lot over the following weeks. He noticed how medical specialties form tribes. Internal medicine versus surgery, academic medicine versus private practice, how these tribes develop their own languages, values, identities, how belonging to a tribe meant accepting certain positions, dismissing certain perspectives. He attended a conference where a surgeon gave a talk about a controversial procedure. The audience response divided perfectly along tribal lines. Surgeons defended it, non-surgeons critiqued it. Nobody seemed to be evaluating the actual evidence. They were just defending their tribe. David raised his hand during Q&A. Can I ask, how many of you actually read the full study rather than just the abstract? Uncomfortable silence. Because I did, and there are some significant methodological concerns that the abstract doesn't mention. The sample size was small, the follow-up period was short, and there were several confounding variables. I'm not saying the procedure doesn't work. I'm saying we don't have good evidence yet that it does. A senior surgeon in the front row turned to look at him. What's your specialty, young man? Internal medicine. Resident. Then perhaps you should leave surgical innovation to surgeons. David felt the room's energy shift against him. He'd violated tribal boundaries. A non-surgeon shouldn't question surgical practice. But then someone else spoke up, a surgeon this time. Actually, I had the same concerns. The study is preliminary. We shouldn't be adopting this widely until we have better data. Others chimed in. The conversation became more honest, less tribal. Not everyone agreed, but at least they were engaging with evidence rather than just defending territory. After the session, the surgeon who'd supported David approached him. That took guts, she said. Medical specialties are basically rival gangs. Crossing tribal lines gets you labeled a traitor. I'm already a traitor to both sides, David said with a slight smile. Physicians think I ask too many questions. Researchers think I'm too clinically focused. Might as well lean into it. Good. We need more traitors. People who care about truth more than tribe. She handed him her card. I'm putting together a working group on evidence-based surgical innovation. You interested? David took the card. Dr. Jennifer Ortiz, professor of surgery, Massachusetts General Hospital. Very interested, he said. That night, David wrote in his journal, I'm learning that engaging with diverse perspectives isn't just about intellectual technique. It's about moral courage. The courage to understand people who disagree with you. The courage to admit when they have a point. The courage to change your mind. The courage to stand against your tribe when your tribe is wrong. It's also about recognizing that perspective isn't just individual. It's cultural, tribal, professional, personal. My perspective as a black male doctor is different from Rebecca's as a Latina female psychiatrist, is different from James's as a white male radiologist. We're all shaped by experiences and identities we don't choose. The hard part is, how do you honor those different perspectives while still believing some things are true and some are false? How do you avoid relativism? Everyone's perspective is equally valid, while also avoiding arrogance. Only my perspective is valid? Sarah says the key is epistemic humility combined with commitment to evidence. Stay humble about what you know, but stay committed to trying to know truly. Respect different perspectives, but don't pretend all perspectives are equally well supported by evidence. I think I'm getting better at this, but I also think it's a practice you never master. Each new situation requires new humility, new openness, new courage. He closed his journal and looked out at the Boston skyline, thinking about voices in rooms, about tribes and truths, about the strange work of trying to understand people who see the world differently than you do. It was harder than solving medical cases, harder than evaluating studies, harder than identifying biases. But it was also, maybe more important, because the world wasn't divided into people who were right and people who were wrong. It was full of people with partial truths, shaped by partial perspectives, doing their best with limited understanding, learning to listen to those voices. Really listen, not just wait to respond, might be the most important critical thinking skill of all. Chapter 7. The Crossroads. Dr. Margaret Foster was dying, and she knew it. Stage 4 pancreatic cancer. 6 months since diagnosis. 2 experimental treatments already failed. Now she sat in David Okonkwo's office. He was covering for her regular oncologist, and asked him a question that had no good answer. Should I try the 3rd trial, or should I go home? David looked at the chart. The trial had a 5% response rate. Severe side effects were common. If she enrolled, she'd spend whatever time she had left in hospital rooms and laboratories, feeling terrible, with minimal chance of benefit. If she went home, she'd have maybe 2 months of reasonable quality before the decline became severe. What do you want to do? David asked, buying time. I want you to tell me what the right choice is. Mrs. Foster, this isn't really a medical decision. It's a values decision. What matters most to you right now? That's why I'm asking you. I've been making decisions my whole life. I'm tired. I want someone else to decide. Her eyes were clear, direct. You're the doctor. You know the odds. Tell me what I should do. David felt the weight of what she was asking. Not information. She had that. Not reassurance. She was past that. She wanted him to carry the burden of an impossible choice, so she didn't have to. He thought about Sarah's lectures on decision-making, about uncertainty and trade-offs and values, about how the hardest decisions weren't between good and bad, but between different kind of good, different kinds of loss. I can't tell you what to do, David said gently, but I can help you think through what matters. Can we talk about what you're hoping for? They spent the next hour mapping her values. Time with her grandchildren versus quantity of time, maintaining dignity versus fighting until the end, being present for her life versus hoping for more life. By the end, she decided, go home, focus on quality, stop fighting. Thank you, she said. You helped me see what I already knew, but was afraid to admit. After she left, David sat in his office, feeling drained. The decision had been hers, but he'd helped her make it. Had he done that well? Had his own biases influenced her? What if she changed her mind in a week? His phone buzzed. A text from Sarah. Tonight's lecture. Bring a hard decision you're wrestling with. The lecture hall felt different that evening. Only about 40 people remained from the original 100 who'd started the seminar. Attrition from the demanding nature of the work, from the discomfort of examining their own thinking, from the time commitment. But the people who remained were different too. More thoughtful, more questioning, more comfortable with uncertainty. They'd been transformed by the process. Sarah began without preamble. Decision-making is where everything we've learned converges. Self-awareness to recognize your biases. Logic to structure your reasoning. Evidence evaluation to assess your information. Perspective-taking to understand trade-offs. All of it comes together when you face a choice that matters. She clicked to a slide showing a simple framework. What are you actually deciding? What are the alternatives? What are your criteria for a good decision? What's the evidence about likely outcomes? What are you uncertain about? What are your biases? How will you know if you were wrong? Most people skip straight to step 2. What are my options? Without clearly defining what they're deciding. That's like a surgeon cutting before they've diagnosed. She walked them through examples. A hospital deciding whether to implement new technology, a patient deciding between treatment options, a physician deciding whether to report colleagues' error. For each one, the group worked through the framework. They found that clearly defining the decision often changed what they thought they were deciding. A choice between treatments became a choice between values. A resource allocation problem became a priority-setting problem. Now, Sarah said, I want you to apply this to a real decision you're facing. Something that matters, something you're genuinely uncertain about. David pulled out his notebook and started writing. Should I pursue the quality improvement position Sarah mentioned, or should I focus on clinical training? He worked through the framework. What was he actually deciding? Not just jobs, career identity. What kind of doctor did he want to be? What did he value more, direct patient care or systemic improvement? The alternatives weren't binary. He could do both in different proportions. He could start clinically focused and shift later. He could do quality improvement within a clinical role. His criteria: intellectual engagement, making a difference, work-life balance, financial security, respect from colleagues. The evidence: quality improvement roles often led to leadership, but less direct patient contact. Clinical roles kept him close to medicine, but limited his systemic impact. His uncertainties: would he be good at quality improvement? Would he miss clinical work? Would this be seen as leaving real medicine? His biases: he wanted to be seen as a serious physician, not an administrator. He was attracted to the novelty of quality improvement because it was new. He was avoiding the harder emotional work of direct patient care. How would he know if he was wrong? If he felt disconnected from patient care? If the work felt bureaucratic rather than meaningful? If he regretted not developing more clinical expertise? By the end of the exercise, David hadn't made a decision, but he understood the decision much better. He saw what he was really choosing between: what he was afraid of, what he valued. Notice what happened, Sarah said to the group. Structured decision-making doesn't give you answers. It gives you clarity. It helps you see what you're actually choosing, what you're trading off, what matters most. Rebecca raised her hand. But what do you do when the structure doesn't help? When you've analyzed everything and you still don't know what to decide? Then you acknowledge that some decisions can't be made rationally. They require judgment, intuition, values that analysis can't resolve. Sarah paused. But even then, the analysis helps. It shows you where the uncertainty lies. It prevents you from making a bad decision for bad reasons. It doesn't guarantee a good outcome, but improves your odds. After the lecture, David found himself in the parking lot with Rebecca and James, none of them quite ready to leave. I applied the framework to my career, Rebecca said. Whether to stay in psychiatry or switch to neurology, I've been agonizing for months. 20 minutes of structured thinking and I knew I need to stay in psychiatry. All my uncertainty was just fear of commitment. I applied it to whether to take a leadership role in my department. James said, realized I was avoiding it not because I thought I'd be bad at it, but because I was afraid people would resent me for it. That's not a good reason to say no. David told them about Mrs. Foster, about the impossible weight of helping someone make a decision that would determine how they spent their remaining time alive. How do you handle that? Rebecca asked, the responsibility of influencing someone's huge life decisions? I don't know, David admitted. I keep thinking, what if I steered her wrong? What if my biases about end-of-life care influenced her choice? Did you tell her what to do? James asked. No. I helped her articulate her values and think through implications. Then you didn't make her decision. You helped her make her own decision. That's different. David knew James was right, but it still felt heavy. The responsibility of helping people think clearly when the stakes were high, when emotions were overwhelming, when time was short. The following week brought a different kind of decision. David was in the ICU when a patient arrested, a 58-year-old man with multiple organ failure. The team worked for 40 minutes, following protocol, doing everything by the book. Nothing worked. The attending looked at the clock, then at David. Call it. David looked at the monitors, the data, the patient. Medically, it was obvious. They'd done everything possible. Further attempts were futile. But calling time of death meant the patient's life was over. It meant telling a family their husband and father was gone. It meant accepting that medicine had limits, that some people couldn't be saved. Time of death, 11:47 p.m., David said. The team dispersed. David went to find the family. In the quiet room where they waited, he delivered the news as gently as he could. The wife broke down. The adult children held each other. David sat with them, answered their questions, gave them time. As he walked back to the ICU, David thought about the decision to stop resuscitation. It had been clear-cut medically, but it was also a decision to stop trying, to accept death, to close the door on possibility. Every day, doctors made dozens of decisions like that, smaller maybe, but still consequential. When to escalate treatment and when to focus on comfort, when to order one more test and when to accept diagnostic uncertainty, when to push a patient toward difficult treatment and when to support their refusal. Each decision carried weight. Each one shaped someone's life or death. Sarah had said critical thinking didn't guarantee good outcomes. But David was realizing something else. Even with the best thinking, even with perfect reasoning, some decisions led to bad outcomes because the world was complex and uncertain and sometimes cruel. The art wasn't just making good decisions. It was living with decisions that didn't turn out well, learning from them without being destroyed by them, staying humble enough to keep trying. Sarah's next lecture addressed exactly that. Decision-making under uncertainty. We want certainty, she said. We want to know we made the right choice. But most important decisions are made with incomplete information, under time pressure, with unclear criteria for success. She introduced them to Bayesian decision theory, the formal framework for making decisions when you're uncertain, starting with prior probabilities, updating based on evidence, calculating expected values. But here's what the math can't tell you, Sarah continued. How much risk you're willing to accept. what you value more when values conflict, what regret you can live with. She told a story from her own life, deciding whether to keep her mother home as the Alzheimer's progressed or move her to a memory care facility. The decision had no right answer. Every option involved loss. I used every framework I teach you. I analyzed the evidence, considered alternatives, examined my biases. In the end, I made a decision. Keep her at home with full-time care. Was it the right decision? I don't know. She's safe, she's with familiar things, but she's also declining faster than she might in specialized care. I won't know for years whether I chose well. The room was silent. That's the nature of consequential decisions. You rarely get clear feedback on whether you chose correctly. You just have to make the best choice you can with what you know, then live with the outcome. David thought about Mrs. Foster, about the patient who died, about his own career decisions, about all the crossroads where he'd have to choose a path without knowing where it led. So, how do you cope with that uncertainty? Someone asked. You build what psychologists call resilience to ambiguity, Sarah said. You get comfortable being uncomfortable. You practice making decisions with incomplete information. You learn from outcomes without overinterpreting them. Sometimes good decisions lead to bad outcomes, and vice versa. And you remember, the goal isn't to never make mistakes. It's to make fewer mistakes over time, catch errors faster, and recover from inevitable failures gracefully. That weekend, David met with Dr. Jennifer Ortiz, the surgeon who'd invited him to her working group on evidence-based surgical innovation. The group was tackling a thorny question. When should new surgical techniques be adopted? Too cautious and patients miss out on beneficial innovations, Jennifer explained. Too aggressive and patients become guinea pigs for untested procedures. We need a framework for making these decisions systematically. David found himself drawing on everything he'd learned, analyzing evidence quality, considering diverse stakeholder perspectives, examining biases toward innovation or conservatism, structuring the decision criteria clearly. They develop a rubric. What's the evidence of efficacy? What's the evidence of safety? What are alternatives? What's the risk-benefit ratio for different patient populations? What's the learning curve? What infrastructure is needed? This is exactly what we need, Jennifer said, reviewing their draft. Structured thinking about consequential decisions. Too often surgical departments make these decisions based on ego or prestige or financial incentives, or fear of being left behind. Added another group member. My department adopted a technique because competitors were using it, not because evidence supported it. David realized this was the work Sarah had alluded to, applying critical thinking to systemic decisions, creating frameworks that help groups make better choices, building cultures where good thinking was valued over quick answers. Have you thought about what you want to do after residency? Jennifer asked him directly. I've been wrestling with that. Clinical work versus quality improvement. Do both. Half-time clinical, half-time quality work. That's what I do. Keeps you grounded in patient care while letting you improve systems. She smiled. You're good at this, David, at helping people think clearly about hard choices. That's a rare skill. That evening, David video called his sister Chioma. She was facing her own crossroads, a job offer in London that would mean leaving Boston, leaving family, leaving the familiar. I don't know what to do, she said. Every time I try to decide, I go in circles. David walked her through Sarah's framework. What are you actually deciding? Not just jobs. Whether prioritize career advancement or family proximity, adventure or stability, short-term discomfort or long-term regret. I think I'm afraid of making the wrong choice, Chioma admitted. What if there is no wrong choice? What if both paths are good, just different? Chioma was quiet for a moment. That's somehow scarier. If one choice was clearly better, I could just pick it. But if both are valid, then I'm really choosing who I want to become. Yeah, that's the hardest kind of decision, when you're choosing identity, not outcomes. They talked for another hour. By the end, Chioma hadn't decided, but she was clearer about what she was choosing between. She thanked David for helping her think it through. After hanging up, David sat with his own clarity. He'd been avoiding his career decision by framing it as either or, clinical or systemic, patient care or quality improvement. But Jennifer had shown him a third path. Both. Half his time with patients. Half improving the systems that serve them. Close enough to clinical work, to stay grounded, far enough to see patterns and make systemic changes. It felt right. Not certain. He'd never have certainty. But right in a way that honored his values, used his strengths, allowed for growth. He called Sarah. "I've made a decision," he told her, "about the quality improvement position. I want to do it, but part-time. Keep half my time clinical." "What helped you decide?" "Realizing I was creating a false dilemma. Also realizing that uncertainty isn't a reason to avoid deciding. I'll never know if it's the right choice until I try it." "That's wisdom," Sarah said. "Making decisions despite uncertainty, then committing to making them work." In his journal that night, David wrote, "Today I learned that decision-making isn't about eliminating uncertainty. It's about acting well despite uncertainty, about gathering what information you can, examining what values you hold, acknowledging what you don't know, then choosing anyway. Every significant decision is a crossroads where you leave one path to take another. You'll never know where the path you didn't take would have led. That's not a bug in decision-making. It's a feature of living. The frameworks help. The structured thinking helps. The bias awareness helps. But ultimately, you have to choose without knowing for certain that you're choosing well. Mrs. Foster chose to go home. I don't know if she'll regret it. I chose to pursue combined clinical and quality improvement work. I don't know if I'll succeed. We're all making our best guesses about uncertain futures. What matters is, are we thinking clearly about our choices? Are we examining our biases? Are we gathering good evidence? Are we honest about our values? Are we willing to learn if we're wrong? If yes, then we're doing the best we can. The outcomes will be what they'll be. But at least we'll know we chose thoughtfully, not carelessly. Deliberately, not reactively. That's all critical thinking can give us. Better odds, clearer vision, more honest self-knowledge. It can't give us certainty, but it can give us courage. The courage to choose, even when we can't be sure. To act, even when we might be wrong. To commit, even when we have doubts. And maybe that's enough. He closed the journal and looked out at the city lights, thinking about crossroads and choices, about paths taken and paths left behind, about the strange courage required to decide anything important when you can never know for sure if you decided well. Tomorrow he'd tell the hospital administration about his decision. Tomorrow he'd begin the next phase of his journey. Tonight, he simply sat with what he'd learned. That wisdom wasn't about always being right. It was about choosing thoughtfully, acting deliberately, and learning continuously from the consequences of your choices. The crossroads would keep coming. He'd keep choosing. He'd keep learning. That would have to be enough. Chapter 8. The practice. 3 months into his hybrid role, half clinical work, half quality improvement, David Okonkwo was learning that knowledge and practice were different things. He understood critical thinking principles. He could teach them to others. But applying them consistently, in real time, under pressure, while exhausted, that was another matter entirely. It was 2 a.m. in the emergency department. David had been awake for 18 hours. A 43-year-old woman with abdominal pain sat in front of him, and his brain was screaming appendicitis. Everything fit. Right lower quadrant pain. Fever. Elevated white blood cell count. Classic presentation. But something made him pause. Maybe it was Sarah's training. Maybe it was exhaustion making him slow down. Maybe it was memory of past mistakes. He ordered a pregnancy test. The nurse gave him a look. She's 43. She says her period stopped 6 months ago. I know. Order it anyway. The test came back positive. Not appendicitis. Ectopic pregnancy. Different diagnosis. Different treatment. Potentially fatal if missed. David sat in the break room afterward, hands shaking from the adrenaline dump. He'd almost missed it. His pattern-matching brain had been so confident, so certain. If he hadn't paused, questioned his own certainty, treated that confidence as a warning sign rather than confirmation, Rebecca found him there an hour later, staring at his coffee. You okay? I almost killed someone tonight. Or at least, I almost made a catastrophic error. Only reason I did was luck and paranoia. What happened? David told her. Rebecca sat down. But you didn't miss it. You caught it. That's not luck. That's good practice. It doesn't feel like good practice. It feels like I'm constantly fighting my own brain, second-guessing everything, never trusting my instincts. Maybe that's what good practice looks like. Maybe critical thinking isn't something you achieve. It's something you do constantly, imperfectly, exhaustingly. Sarah's next lecture addressed exactly this. The gap between knowing and doing. You've all learned frameworks for critical thinking, she began. You understand biases, logic, evidence evaluation, decision-making. But here's the uncomfortable truth. Knowing doesn't translate automatically to doing. The gap between knowledge and practice is where most people fail. She clicked to a slide showing a simple equation. Knowledge plus practice plus environment equals habit. Critical thinking has to become habitual, automatic enough that you do it even when tired, stressed, or overwhelmed. But habits aren't formed by understanding alone. They're formed through deliberate practice in supportive environments. She introduced them to the concept of critical thinking triggers, specific situations or feelings that should automatically activate more careful thinking. Feeling very certain? That's a trigger. Time pressure? Trigger. High stakes? Trigger. Strong emotional reaction? Trigger. When you notice these conditions, you shift from automatic to deliberate thinking. David recognized what she was describing. The pregnancy test case. His certainty had been the trigger. He'd learned to treat his own confidence as a warning sign. But triggers only work if you practice a response, Sarah continued. If you've rehearsed what you do when triggered. Otherwise, you'll notice you should slow down, but not actually slow down. She walked them through developing personal practice routines. Daily reflection on decisions. Weekly review of errors and near misses. Monthly meta-analysis of thinking patterns. Annual deep dive into blind spots and biases. This isn't optional, Sarah said. Professional athletes don't just play games. They train constantly. Musicians don't just perform. They practice daily. If you want critical thinking to be your default mode, you have to practice it deliberately, not just hope it happens during important moments. David started building routines. Every morning before rounds, he spent 15 minutes reviewing his previous day's decisions. Not all of them, just the ones where he felt uncertain, where he'd had to make judgment calls. What had he decided? Why? What evidence had he used? What alternatives had he considered? What biases might have influenced him? What would he do differently now? At first, the practice felt artificial, forced. He'd write dutiful entries in his journal, checking boxes more than actually reflecting. But gradually, something shifted. The questions became natural. He started noticing patterns in his thinking. He was more prone to anchoring bias in the morning when he was fresh but overconfident, more prone to availability heuristic late in the day when he was tired, and reaching for easily remembered solutions. He was more likely to dismiss patient concerns when he was busy, more likely to order unnecessary tests when he felt defensive, more likely to accept superficial explanations when the alternative was confronting uncomfortable truths. The awareness was uncomfortable. It would have been easier not to see these patterns, but seeing them meant he could work around them. One morning, David presented his routine to the quality improvement team he now co-led. I think we should build reflection time into clinical workflows, he said. Require 5 minutes after complex cases or difficult decisions for structured reflection. The pushback was immediate. We don't have time for that, someone said. We barely have time to see all our patients as it is. But we have time to fix the errors that come from not thinking carefully, David countered. How much time did we spend last month on that medication error? That wrong site surgery near miss? That delayed diagnosis that became a lawsuit? The room was quiet. I'm not saying reflection prevents all errors, but it helps you catch patterns before they become crises. It takes 5 minutes. Most errors cost hours or days to fix. They piloted the program in 1 unit. Doctors and nurses were skeptical at first, but after a month, several noticed they were catching errors earlier, communicating more effectively, feeling less defensive about feedback. It's like having a reset button, one nurse said. 5 minutes to step back and think about whether you're thinking clearly. It sounds stupid, but it works. The program expanded to other units. Not everyone participated. Some physicians dismissed it as touchy-feely nonsense. But enough did that the culture started shifting. Reflection became less weird, more normal. The environmental component proved crucial. David could practice critical thinking individually, but if the hospital culture punished questioning and rewarded certainty, his practice would erode under pressure. He saw this clearly during a morbidity and mortality conference, a monthly meeting where the department reviewed cases with bad outcomes. Traditionally, these meetings focus on finding who was to blame. Someone made an error. The group identified it. Lessons were supposedly learned. David proposed restructuring them around systems thinking. Instead of who screwed up, ask what conditions made this error likely. Instead of individual blame, examine the environment, incentives, time pressures, communication failures. The first reformed M&M meeting was uncomfortable. Dr. Richard Chen, a senior physician, presented a case where he'd missed a diagnosis that led to patient harm. But instead of focusing on his individual error, they examined the system factors. Incomplete information transfer from the ER, electronic health record interface that buried crucial lab values, time pressure from being double-booked, no easy way to consult specialists. I made the error, Dr. Chen said, but the system set me up to make it. A dozen other doctors would have made the same mistake in the same conditions. They identified concrete changes, redesigned the EHR interface, improve ER-to-floor handoff protocols, adjust scheduling to reduce double booking, create rapid specialist consultation pathway. This feels better, Chen admitted after. Usually M&M meetings are just public shaming disguised as education. This actually helps. Sarah invited David to co-teach one of her lectures on building critical thinking environments. He talked about the M&M meeting redesign, the reflection practices, the cultural shifts. The individual is important, he said. You have to personally commit to thinking critically, but you're embedded in systems, teams, departments, organizations. If those systems punish good thinking or reward bad thinking, your individual practice will erode. He shared examples of toxic environments he'd observed. Departments where questioning senior physicians got you labeled as difficult, where admitting uncertainty was seen as weakness, where speed was valued over accuracy, confidence over humility. Critical thinking requires psychological safety, David said. The security to say I don't know or I might be wrong, or I need help, without fear of humiliation or retaliation. Without that safety, people will default to whatever keeps them safe, not whatever helps them think clearly. A medical student raised her hand. How do you create that safety when you're junior, when you have no power to change the culture? David thought about his own experience. You start small. You model the behavior you want to see. You respond to others' uncertainty with curiosity instead of judgment. You admit your own mistakes openly. You ask questions that make it safe for others to question. And sometimes, Sarah added, you vote with your feet. You find environments that support good thinking and avoid ones that punish it. Not everyone can do that. Not everyone has options. But for those who do, choosing your environment is choosing what kind of thinker you'll become. David's sister Chioma had taken a London job. They video called weekly, and David had been coaching her through building critical thinking practices in her new role. It's harder here, she said during one call. The consulting culture is all about confidence and quick answers. If you admit uncertainty, clients think you're incompetent. So, how do you stay honest while appearing confident? I've been experimenting. Instead of I don't know, I say here's what I'm confident about and here's what's still uncertain. Instead of one recommendation, I offer options with clear trade-offs. Instead of hiding my reasoning, I show my work. How's that going? Mixed. Some clients love it. They feel like I'm treating them as intelligent partners instead of just telling them what to do. Others find it frustrating. They want simple answers, even if simple answers are wrong. They talked about the tension between what clients wanted and what good thinking required, about the pressure to oversimplify complex situations, about the temptation to pretend certainty you didn't feel. The weird thing is, Chioma said, being more honest about uncertainty has actually made clients trust me more. When I say I'm confident about something, they believe me. because they've seen me admit when I'm not confident. Selective certainty has more credibility than blanket certainty. David filed that insight away. It matched his experience in medicine. Patients trusted him more when he distinguished between what he knew for sure and what he was inferring. The practice of critical thinking, David was learning, had rhythms, daily practices for maintenance, weekly practices for pattern recognition, monthly practices for course correction, annual practices for deep reflection. But it also had failures. Days when he was too tired to think carefully. Cases where he reverted to pattern matching despite knowing better. Meetings where he stayed silent instead of questioning flawed reasoning. Moments where fear of conflict overrode commitment to truth. He brought one such failure to Sarah during their coffee meeting. "I let the team make a bad decision yesterday," he confessed. In a quality improvement meeting, the proposed solution was politically convenient, but wouldn't actually fix the problem. I knew it. I stayed quiet. Why? Because the person proposing it was senior. Because I was tired of being the person who always has objections. Because I wanted to be agreeable for once. "So, what are you going to do about it?" I went back this morning. I asked to reopen the discussion. I presented my concerns more carefully. Not this won't work, but here are some implementation challenges we should address. And they listened. We revised the plan. It's better now. David paused. But I hate that my first instinct was silence, that I had to course correct instead of getting it right the first time. "Welcome to being human," Sarah said. "You're never going to get it right every time. The practice isn't about perfection. It's about noticing when you fail and recovering quickly." She told him about her own recent failure. A research meeting where she dismissed a junior colleague's observation because it contradicted her hypothesis. She'd realized it only later, had to apologize, had to revise her thinking. "I teach critical thinking," Sarah said. "I've been practicing it for 20 years. I still mess up regularly. The difference is I mess up less than I used to, and I catch myself faster." That evening's lecture focused on long-term practice, how to sustain critical thinking over years, not just weeks. "You'll get tired," Sarah said bluntly. "Constant vigilance about your own thinking is exhausting. You'll want to stop, to just trust your intuitions, to think fast instead of carefully." She acknowledged the real costs. The time, the mental energy, the social friction from questioning group consensus, the discomfort of uncertainty, the loss of the comfort that certainty provides. So why continue? Not because it's easy, not because it's comfortable, but because the alternative, thinking carelessly about important things, has consequences you're not willing to accept. She shared data on medical errors, flawed decisions, organizational failures. Most trace back to thinking failures, not lack of knowledge, but failure to apply knowledge carefully. Every patient harmed by a preventable error is a failure of thinking. Every organizational crisis caused by foreseeable problems that weren't foreseen is a failure of thinking. Every personal regret from choices made carelessly is a failure of thinking. Critical thinking won't prevent all of these, but it reduces them. And that reduction, fewer errors, fewer crises, fewer regrets, is worth the cost of the practice. In his journal that night, David wrote about practice and failure, about systems and individuals, about the daily work of thinking well. "I used to think critical thinking was about being smart. Now I know it's about being disciplined, about building habits that persist even when you're tired, stressed, or overwhelmed. The frameworks help, the techniques help, but what really matters is the daily practice of applying them, the weekly review of how you're doing, the monthly assessment of patterns, the yearly deep dive into growth areas. I'm better at this than I was 6 months ago. I catch myself sooner. I question my certainty more readily. I seek out perspectives that challenge mine. I structure important decisions more carefully. But I'm far from perfect. I still make mistakes. I still let biases slip through. I still take mental shortcuts when I should slow down. The difference is I notice, I correct, I learn, and I'm building an environment that supports this work. A team that values good thinking. A culture that makes questioning safe. Systems that catch errors before they become catastrophes. Sarah's right. This is lifelong work. There's no point where you've mastered it and can stop practicing. It's like physical fitness or musical skill, or any other practice that requires constant engagement, but it's also cumulative. Each day of practice makes the next day easier. Each error caught makes the next error more visible. Each good decision makes the next good decision more likely. That's what I'm building. Not perfection, but trajectory. Not flawlessness, but improvement. Not certainty, but wisdom. One day, one decision, one reflection at a time. He closed a journal and looked at his calendar. Tomorrow, 12 patient appointments, 2 quality improvement meetings, a teaching session with medical students, Sarah's lecture on resilience and critical thinking under pressure. A full day, multiple opportunities to practice, multiple opportunities to fail and recover and learn. He smiled slightly. 6 months ago, that schedule would have felt overwhelming. Now it felt like what it was, a day full of opportunities to practice thinking well. That was the shift he realized. From seeing critical thinking as something you learned to seeing it as something you practiced. From endpoint to process. From achievement to discipline. The practice continued, would always continue. And that was exactly as it should be. Chapter 9. The fire. The alarm sounded at 3:47 a.m. Mass casualty incident. A fire at a downtown apartment building. All available personnel to the emergency department. David Okonkwo arrived within 20 minutes to controlled chaos. Victims were already streaming in. Smoke inhalation, burns, traumatic injuries from jumping from windows. The triage area was overwhelmed. The trauma bays were full. Okonkwo, you're with me, Dr. Linda Martinez called. We got critical patients incoming. For the next 6 hours, David operated in a blur of decisions. This patient needs intubation immediately. That one can wait. This burn needs urgent debridement. That head injury needs CT now. Prioritize the airway. Control the bleeding. Check for carbon monoxide poisoning. There was no time for structured thinking, no space for careful analysis. Just rapid-fire decisions based on pattern recognition, protocol, and whatever clarity he could summon through the exhaustion and adrenaline. Around 9 a.m., the flow finally slowed. David found himself in the staff break room, hands shaking from caffeine and stress, reviewing what had happened. He'd made dozens of critical decisions. He couldn't even remember all of them. Had he made the right calls? Had his shortcuts been accurate, or had he fallen into bias traps? Had anyone died because he thought too fast or too slow? Sarah Chen appeared in the doorway. She'd been called in as a consultant for neurological injuries. You did good work out there. I don't know what I did, David admitted. I was just reacting. All that careful thinking we practice. None of it was there. Just instinct and panic. Come with me, Sarah said. They walked to her office. Sarah pulled out a notebook and handed it to David along with a pen. Write down every major decision you remember making. Don't judge them. Just document them. David wrote for 30 minutes, reconstructing the morning, the intubation he'd performed, the patient he'd sent straight to surgery, the family he'd had to tell their daughter hadn't made it, the resource allocation decisions when demand exceeded supply. Now, Sarah said, let's examine them. Not to criticize, to learn. What were you thinking in each moment? They went through the list systematically. Most of David's decisions, under scrutiny, held up. He'd followed protocols appropriately. His pattern recognition had been accurate. His prioritization had been sound given constraints. But there were errors. A patient he'd initially triaged as moderate, who turned out to be critical. A treatment he'd started based on assumed diagnosis that proved wrong. A family conversation he'd rushed because he was overwhelmed. These aren't failures, Sarah said when they finished. They're the inevitable results of making high-stakes decisions under extreme pressure with incomplete information. What matters is, how do you learn from them? I don't know. I can barely remember making them. That's the problem. When you're in System 1 crisis mode, you don't form good memories of your reasoning process, so you can't learn from it effectively. Sarah pulled out another sheet of paper. This is why elite performers in high-pressure fields, surgeons, pilots, military personnel, practice scenario-based training, not just to build skills, but to build a capacity to think clearly under stress. She explained the concept of stress inoculation, deliberately practicing in stressful conditions to build resilience and maintain cognitive function under pressure. Your regular critical thinking practice builds a foundation, but you also need practice thinking critically when you're tired, stressed, overwhelmed, or afraid. Otherwise, when real crises hit, you revert to pure instinct, which is sometimes right but not always. That evening's lecture, which David attended despite his exhaustion, focused on critical thinking under adversity. Most of what we practice assumes relatively calm conditions, Sarah began. You have time to reflect, energy to analyze, emotional resources to examine your biases. But real life isn't always calm. Sometimes you face crisis, medical emergencies, personal disasters, organizational chaos. What happens to your critical thinking then? She clicked to a slide showing the Yerkes-Dodson curve. Performance increases with arousal up to a point, then sharply decreases. Moderate stress can actually enhance performance. It focuses attention, increases energy, sharpens decision-making. But extreme stress degrades cognitive function. Your prefrontal cortex, the part that does careful thinking, essentially goes offline. You revert to faster, more primitive processing. She described the physiological cascade: amygdala activation, cortisol release, narrowed attention, reduced working memory, impaired impulse control, all the things that made careful thinking difficult. So what do? 3 things: preparation, protocols, and recovery. Preparation meant practicing under stress, simulated emergencies, difficult role plays, time-pressured decisions, building the mental pathways so that good thinking became more automatic. Protocols meant pre-committing to structures when you were calm that would guide you when you weren't. Checklists, decision trees, bright-line rules about when to slow down and consult others. Recovery meant deliberately processing high-stress events afterward, reviewing decisions, learning lessons, preventing trauma from calcifying into dysfunctional patterns. The fire this morning, Sarah said, looking at David, was extreme. Nobody expects perfect critical thinking in those conditions, but you can expect to learn from them, to identify what worked, what didn't, and how to do better next time. Over following days, David was involved in the hospital's critical incident debriefing. The entire response team gathered to review what had happened, what had gone well, what had gone poorly. Initially, the meeting had the defensive feeling of a potential blame session, but David suggested using Sarah's framework, examining the system, not just individuals. "I made errors this morning," he said. "We all did. That's inevitable in mass casualty situations. The question isn't who screwed up, it's what conditions made errors more likely and how we can improve those conditions." They identified issues: communication protocols that broke down under load, triage systems that didn't scale well, unclear authority structures, inadequate supplies in certain areas, no clear process for family communication. But they also identified successes: good teamwork, effective improvisation, appropriate resource allocation given constraints, excellent individual clinical care. "What I noticed," Rebecca Torres said, "was that the people who did best were the ones who practiced for chaos. The trauma team runs drills monthly. They had muscle memory for the coordination. The rest of us were figuring it out on the fly." That observation led to a proposal: regular mass casualty drills for all staff, not just trauma specialists. Practice thinking clearly under pressure. Build the neural pathways before they were needed in real crisis. 2 weeks later, David participated in his first simulation. Fake patients, simulated injuries, artificial time pressure. It felt silly at first. Everyone knew it wasn't real. But Sarah, who was facilitating, kept increasing the stress. More patients than they could handle. Missing equipment. Contradictory information. Personality conflicts within the team. By 30 minutes in, David's heart was racing and his thinking had narrowed to pure triage mode. They stopped, reviewed the video. David was shocked by what he saw. "I missed obvious things," he said, watching himself overlook a patient's deteriorating condition because he was focused elsewhere. "I got tunnel vision." "Exactly," Sarah said. "That's what stress does. You had more information available than you used. You didn't delegate when you should have. You made snap judgments without checking them. They ran the scenario again. This time, David performed better. He remembered to delegate, force himself to do quick systematic assessments rather than relying on gestalt impressions, pause for 3 seconds before major decisions, even though it felt like he didn't have 3 seconds. Better, Sarah said. Not perfect. Perfection is impossible in these conditions, but better. You maintain more cognitive function under pressure. Over months of simulations, David built resilience. He learned his personal stress responses. He got quieter when overwhelmed, more authoritarian when anxious, more likely to miss details when rushing. Learning these patterns meant he could watch for them, compensate for them. But resilience wasn't just about acute stress. It was also about chronic pressure, the slow grind of difficult circumstances that eroded judgment over time. David noticed this in himself around month 8 of his hybrid role. He was tired all the time. His decision quality was declining. His reflection practice had become perfunctory. He was shorter with colleagues, less patient with ambiguity, more defensive about feedback. He brought it up with Sarah during their coffee meeting. I think I'm burning out, and I think it's affecting my thinking. Tell me more. I'm making more mistakes. Little ones, mostly, but they're adding up. I'm less careful about checking my biases. I'm more likely to just accept the easy answer instead of digging deeper. It's like my intellectual immune system is compromised. Sarah nodded. Cognitive fatigue is real when your resources are depleted. From overwork, stress, lack of sleep, emotional demands, your capacity for careful thinking decreases. System 2 is expensive in terms of mental energy. When you're depleted, you default to System 1 more. So what do? Same thing you do for physical exhaustion, rest and recovery, but for cognitive resources. Sarah pulled out a sheet with what she called mental energy hygiene. Sleep, exercise, time away from decision-making, activities that restore rather than depleted, social connection, meaning-making, things that refilled the tank of mental resources. You can't think critically all the time, Sarah said. You need downtime. Your brain needs recovery periods. Otherwise, you're trying to run a marathon without ever stopping to drink water. David realized he'd been treating critical thinking like a muscle to exercise constantly, but he also needed to treat it like a muscle that required rest to grow stronger. He started building recovery practices. 1 full day per week away from medical decisions. Morning runs that cleared his head. Time with friends where he didn't have to be on. Reading for pleasure instead of just professional development. The difference was noticeable. He had more mental energy. His decision quality improved. The reflection practice felt meaningful again rather than obligatory. But he also learned about limits. One afternoon, after an especially difficult patient death, David found himself unable to focus. His mind kept returning to the case, questioning every decision, spiraling into harsh self-criticism. He called Rebecca. I think I need help processing this. They met for coffee. David told her about the case. An elderly man who'd seemed stable, then crashed unexpectedly. The family was devastated. David kept replaying it, wondering what he'd missed. Did you make an error? Rebecca asked. I don't know. Maybe. The decline was sudden, but maybe there were subtle signs I didn't catch. Or maybe some patients just die unexpectedly, and it's not about your clinical judgment. They talked through it. Eventually, David could see that he'd made reasonable decisions with the information available. The outcome was tragic, but not necessarily preventable. I think this is what Sarah means about recovery, Rebecca said. Sometimes you need help processing difficult experiences, so they don't calcify into distorted beliefs about yourself. Otherwise, one bad outcome makes you doubt everything, and doubt can be as dangerous as overconfidence. Sarah's next lecture addressed exactly this. The psychological impact of being a critical thinker in a world that often punished honesty and rewarded certainty. There's a cost to seeing clearly, she said. Once you develop critical thinking skills, you can unsee problems. You notice flawed reasoning, biased judgments, poor decisions, in yourself and in others. That awareness can be isolating and exhausting. She acknowledged the temptation to stop thinking critically, to just accept things at face value, to trust authorities without questioning, to stop carrying the burden of careful judgment. But here's what I've learned over 25 years. The cost of awareness is less than the cost of blindness. Yes, thinking critically is work. Yes, it's uncomfortable. Yes, it sometimes makes you unpopular. But the alternative, making consequential decisions carelessly, accepting comfortable lies, letting biases operate unchecked, has costs you're not willing to pay. She talked about building resilience, finding communities of fellow critical thinkers, developing practices for managing the stress of uncertainty, learning to accept that some things can't be known or fixed, maintaining compassion for yourself and others in the face of inevitable cognitive failures. You're going to make mistakes, Sarah said. You're going to fail at thinking critically sometimes. You're going to let biases slip through, make poor decisions, miss important information. The question isn't whether you'll fail. It's how you'll respond when you do. She introduced the concept of error recovery, the ability to notice mistakes quickly, correct them effectively, and learn from them without being destroyed by them. Resilient critical thinkers aren't people who never make errors. They're people who have healthy relationships with their errors, who can acknowledge them without shame spiraling, learn from them without defensiveness, and move forward without being paralyzed by perfectionism. In his journal that night, David wrote about fire and resilience, about stress and recovery, about the ongoing challenge of thinking well when circumstances made it hard. I used to think critical thinking was primarily cognitive, about logic and evidence, and avoiding biases. Now I understand it's also emotional and physical, about managing stress, maintaining energy, recovering from failures, processing difficult experiences. The fire taught me that extreme stress degrades thinking, but it also taught me that practice under stress builds capacity, that protocols and preparation help maintain function when pure willpower fails. The months of chronic pressure taught me that cognitive resources are finite, that you can't think carefully all the time without rest, that recovery isn't weakness, it's necessary maintenance. The patient death taught me that some outcomes hurt regardless of whether you made errors, that self-criticism can be as biased as self-justification, that sometimes you need others to help you think clearly about your own thinking. Sarah's right. There's a cost to seeing clearly, but there's also a strength in it, the ability to face difficult truths, to acknowledge uncertainty, to keep thinking carefully even when it's hard. That's a kind of courage. I'm not where I want to be yet. I still make too many errors. I still let stress degrade my judgment. I still struggle with the emotional toll of clinical work combined with constant self-examination. But I'm better than I was, more resilient, more aware of my limits and how to work within them, more capable of thinking clearly under pressure, and of recovering when pressure exceeds my capacity. That's what resilience means, not invulnerability, but the ability to bend without breaking, to fail without being defeated, to keep trying to think, well, even after you've thought poorly. The fire tests the metal. I'm learning I'm stronger than I thought, and also more vulnerable than I thought. Both are true. Both matter. Tomorrow, I'll face new challenges, new opportunities to think clearly or to fail at thinking clearly, new chances to practice resilience. I'll do my best. I'll fail sometimes. I'll recover. I'll keep going. That's all anyone can do. It's enough. David closed the journal and sat for a moment in the quiet of his apartment. Outside, Boston hummed with its usual nighttime energy. Inside, he felt something settling, not certainty, but a kind of grounded acceptance. The work was hard, would always be hard, but he was becoming someone who could do hard things, who could think clearly even when it was difficult, who could fail and recover and keep going. The fire hadn't destroyed him. It had tested him, refined him, made him stronger. Tomorrow, there would be new fires, new tests, new opportunities to practice resilience and critical thinking under pressure. He was ready, not because he was perfect, but because he'd learned that perfection wasn't the goal. Persistence was. And he had plenty of that. Chapter 10. The Inheritance. The medical student was crying in the conference room. David Okonkwo sat across from her, uncertain what to do. Emily Zhang had just presented a patient case to the attending physician, who'd torn apart her reasoning in front of the entire team. "I'm so stupid," Emily said through tears. "I should have known. It was obvious." "It wasn't obvious," David said quietly. "The presentation was atypical. Even experienced physicians would have struggled with it. But Dr. Morrison knew immediately. He made me look like an idiot." David thought about his own medical school experience. The shame of being wrong in front of others, the fear of looking stupid, the way humiliation could shut down learning rather than facilitate it. He thought about everything Sarah had taught him about psychological safety and growth mindsets. "Can I tell you what I see?" David asked. "I see someone who made a reasonable initial hypothesis based on limited information, then failed to update when new data came in. That's not stupidity. That's a specific cognitive error called anchoring bias. It's correctable." Emily looked up. "What?" "You anchored on your first impression and filtered subsequent information through that lens. It's one of the most common thinking errors in medicine. I do it at least twice a week." David pulled out a sheet of paper. "Let me show you something." He drew out the case, showing Emily where her reasoning had been sound and where it had gone wrong. Not "you're smart" or "you're dumb," but "here's what you did well, here's where the error occurred, here's how to catch it next time. Why are you telling me this?" Emily asked. "Because someone did it for me, and it changed how I think about thinking." That evening, David met with Sarah to discuss a proposal he'd been developing. He wanted to create a critical thinking curriculum for medical students, a formal program integrated into their training. "The way we teach medicine now," David explained, "we focus on knowledge and procedures. We assume students will somehow absorb good thinking habits through osmosis. But they don't. They absorb whatever habits their attendings model, good or bad." Sarah leaned back in her chair. "You're describing a cultural shift. Those are hard." "I know, but I think we have to try. Every preventable medical error, every misdiagnosis, every poor decision, they trace back to thinking errors. If we don't teach people how to think, we're just teaching them what to think. And what to think changes constantly." They worked through proposal, core concepts, metacognition, bias recognition, evidence evaluation, decision frameworks, intellectual humility, pedagogical approach, case-based learning, deliberate practice, peer feedback, reflective journaling, assessment, not exams, but portfolio of thinking processes. "The hardest part will be faculty buy-in," Sarah said. "Many physicians don't believe critical thinking can be taught. They think you either have it or you don't. Then we'll have to prove them wrong." The proposal faced immediate resistance. At the curriculum committee meeting, Dr. Harold Morrison, the same physician who'd humiliated Emily, spoke first. "Medical students don't need more theory. They need more clinical exposure, more procedures, more facts. This touchy-feely metacognition nonsense is a waste of time." David had prepared for this. "Can I ask a question? What percentage of medical errors would you say come from lack of knowledge versus errors in applying knowledge?" "Most errors are knowledge deficits." "Actually, studies show the opposite. Most errors come from cognitive factors, fatigue, anchoring bias, confirmation bias, failure to consider alternatives. Students know what they need to know. They just don't think carefully about what they know. That's speculation." "No, it's research." David pulled up a slide showing data from multiple studies on medical error causation. Knowledge deficits account for less than 20% of diagnostic errors. The rest are reasoning failures. The room was quiet. Then Dr. Jennifer Ortiz spoke up. "I'd support a pilot. One cohort of students measure outcomes, compare to controls." Others nodded. The committee agreed to a trial. 12 students, 1 semester, careful evaluation. David's first session with the pilot group was nerve-wracking. 12 third-year medical students sat looking at him skeptically. They were tired, overwhelmed with information, uncertain why they were there. "This isn't a lecture course," David began. "You're not here to learn facts. You're here to learn how to think about your thinking, metacognition." "Why?" one student asked. "We barely have time to learn what we need to learn. Now we're supposed to think about thinking too. Because thinking about thinking makes learning more efficient. You'll retain more, apply better, make fewer errors. David clicked to his first slide. But don't take my word for it. Let's test it. I'm going to show you a patient case. Write down your initial diagnosis. He presented a case with classic appendicitis symptoms. Everyone wrote appendicitis. Now I'm going to give you one additional piece of information. The patient is pregnant. Does that change your diagnosis? Half the students stuck with appendicitis. Half changed their answers. Why did some of you change and others didn't? The discussion revealed something fascinating. The students who changed had asked themselves, what else could this be? The ones who didn't had accepted their first answer without questioning it. That's the difference, David said. Not knowledge. Both groups knew pregnancy changes appendicitis presentation. The difference was metacognitive awareness. Ask, am I sure, before committing to an answer. He saw several students sit up straighter, more engaged. Over the semester, David taught them the frameworks Sarah had taught him. They practiced identifying biases in real cases. They role-played difficult conversations requiring intellectual humility. They kept journals examining their decision-making processes. The resistance was real. Some students found it too abstract, too theoretical. They wanted concrete facts, not fuzzy thinking skills. But others had transformations similar to David's own. Emily Zhang, who joined the pilot program after the humiliation incident, became one of the strongest advocates. I used to think being smart meant knowing the answers, she told the group during a reflection session. Now I realize being smart means knowing how to think through uncertainty. These skills matter more than memorization. The semester ended with assessment. David compared the pilot group to controls on several metrics: diagnostic accuracy on complex cases, ability to recognize and correct errors, quality of clinical reasoning during evaluations. The results were striking. The pilot group performed better on every measure. Not dramatically. Critical thinking wasn't magic, but consistently, measurably better. More importantly, they reported feeling more confident in their reasoning, more comfortable with uncertainty, more able to recognize when they needed help. The curriculum committee expanded the program. Then the medical school adopted it as a required course. Other hospitals started asking David consult on their training programs. But teaching students was only one part of creating lasting change. David also had to address the culture that students entered, the attending physicians, the residency programs, the institutional norms. He proposed reforming teaching rounds to model better thinking practices. Instead of pimping, asking questions designed to embarrass students who didn't know answers, use questions that made thinking visible. When I present a case now, David explained to the attending physicians, I don't ask, what's the diagnosis? I ask, were you thinking? What makes you confident? What are you uncertain about? What would change your mind? That's coddling, Morrison said. Students need to learn to handle pressure. There's a difference between pressure and humiliation. Pressure can enhance learning. Humiliation shuts it down. David pulled up more research. Students who experience shame-based teaching have higher burnout rates, lower diagnostic accuracy, and are more likely to hide errors instead of learning from them. Rebecca Torres, now attending as a psychiatry consultant, added her perspective. The goal isn't to make students comfortable. It's to make them safe. Safe to admit uncertainty. Safe to ask questions. Safe to make mistakes. That's how learning happens. Gradually, some attendings shifted their approach. Not all. Change was slow, but enough that students noticed. The culture began to shift from never be wrong to think carefully about when you might be wrong. Sarah's final lecture of the year addressed legacy, how to create lasting change rather than temporary improvement. Individual change is important, she said, but individual change alone is fragile. If you become a better thinker, but the systems around you punish good thinking, your improvements will erode. Real change requires changing culture, institutions, incentives. She talked about leverage points, places where small interventions could create large effects, teaching programs that shaped new physicians, promotion criteria that rewarded intellectual humility alongside clinical excellence, peer review systems that examine reasoning processes, not just outcomes. Each of you will face a choice, Sarah said, looking out at the audience. You can become excellent critical thinkers and keep that excellence to yourself. Or you can become teachers, spreading these skills to others, changing systems to support better thinking, creating environments where clear thought can flourish. The first path is easier. The second is more important. She looked directly at David. Some of you will take the harder path. You'll build programs, reform institutions, challenge entrenched norms. You'll face resistance. People will tell you you're wasting your time, that thinking can't be taught, that the old ways work fine. But you'll persist, because you'll have seen what's possible. You'll have experienced a transformation in yourself and watched it happen in others. You'll know that better thinking leads to better decisions, which leads to better outcomes, which leads to less suffering. That knowledge creates responsibility. Once you see how to reduce preventable harm through better thinking, you can't unsee it. You can't go back to accepting careless thought as inevitable. After the lecture, Sarah asked David to stay. They walked to her office in comfortable silence. "I'm stepping back from teaching," Sarah said once they'd settled in. "Not retiring, just refocusing on research. I'm going to need someone to take over the critical thinking seminar." David felt a jolt of surprise mixed with fear. "Sarah, I'm not qualified." "You're more qualified than you think. You've lived the transformation. You've applied these skills in practice. You've taught others successfully. Most importantly, you believe in the work. But you're the expert. People come to learn from you. And they'll come to learn from you. Not because you're perfect, you're not, and neither am I, but because you can show them what the journey looks like. The struggles and failures alongside the successes. That's more valuable than expertise." They talked for 2 hours about logistics, curriculum design, how to handle difficult situations. But mostly, Sarah talked about philosophy, why this work mattered, how to sustain it over years, what traps to avoid. "The biggest trap," Sarah said, "is thinking you have it all figured out. The moment you stop questioning your own thinking is the moment you stop being useful as a teacher. Your students will teach you as much as you teach them, if you let them. Will you still be available for consultation?" "Of course. But David, you don't need me anymore. You have the foundation. Now you need to build your own approach, make your own mistakes, find your own voice." David's first session teaching the seminar alone was terrifying. 60 people in the lecture hall, all looking at him expectantly. No Sarah to fall back on if he stumbled. He started with honesty. "I'm nervous. This is my first time teaching this course solo. I'm going to make mistakes, probably say things unclearly, maybe get some things wrong. If that happens, I hope you'll tell me. Good teaching requires intellectual humility, and I'm still learning that." The admission seemed to relax the room. He was human, fallible, still learning, just like them. He told them his story, the meningioma case that started his journey, the failures and insights along the way, the ongoing struggle to think clearly under pressure. He didn't position himself as an expert who'd mastered critical thinking, but as a practitioner who'd learned to practice it better. "Critical thinking isn't something you achieve once and file away," David said. "It's something you practice daily, imperfectly, with constant course correction. I still make thinking errors. I still let biases influence my judgment. I still struggle with uncertainty. But I catch myself more often now, and I recover faster when I fail." He introduced frameworks, walked through cases, facilitated discussions. The session ended with several people thanking him, saying his honesty made the material more accessible. Rebecca found him afterward. "You were good, really good. Different from Sarah, but in a good way. She taught from mastery. You teach from journey. Both work." Over the following months, David developed his own teaching style. He incorporated more simulation and role-play than Sarah had. He brought in guest speakers, the infection control nurse who'd helped solve the hospital-acquired infection problem, the surgeon Jennifer Ortiz who reformed surgical innovation processes, his father who spoke about decision-making in small business. He created peer teaching opportunities where students taught frameworks to each other. He built in more reflection time. He made the course more explicitly about creating institutional change, not just individual improvement. The enrollment grew. Students told other students. Residents requested sessions. Attending physicians started sitting in. The seminar that had started with 100 people dwindled to 40, now filled lecture halls. But David's proudest moment came 6 months into his teaching when Emily Zhang, the student who'd been crying in the conference room, gave a presentation at a medical education conference on implementing critical thinking curricula. She was passionate, articulate, and convincing. Dr. Okonkwo changed how I think about medicine, Emily said in her talk. But more importantly, he showed me I could change how others think about medicine. That's the inheritance, not just the skills, but the responsibility to pass them on. Watching from the audience, David felt something settle. This was the work, not just becoming a better thinker, but helping others become better thinkers. Not just solving problems, but teaching others to solve problems. Not just making good decisions, but creating environments where good decisions were more likely. The inheritance wasn't information. It was transformation. And transformation spread through modeling, teaching, culture building, system reform. That evening, David visited Sarah at her home. Her mother was there, more declined now, barely recognizing Sarah on good days. "How's teaching going?" Sarah asked over tea. "It's hard. Rewarding, but hard. I understand now why you kept doing it, even when it was exhausting. Because it matters. Because it compounds. Every person who learns to think better influences dozens of others. Every system reform makes thousands of better decisions possible. It scales in ways that individual practice doesn't." Sarah smiled. "You found the leverage point. Individual excellence is good. Teaching others to be excellent is better. Changing systems that shape thousands of people is best. You're working at all 3 levels now." They talked about the future. David's plans to expand the program, to consult with other hospitals, to research effective teaching methods for critical thinking. Sarah offered advice, shared her own mistakes and insights, connected him with colleagues who could help. As David prepared to leave, Sarah's mother looked up from her chair, where she'd been sitting quietly. "You're teaching?" she asked clearly, a moment of lucidity. "Yes," David said. "Good. Teaching is how we survive death. The ideas live on." The moment passed. Her clarity faded, but the words hung in the air. Sarah walked David to the door. "She taught me that before the Alzheimer's," she said, "the only immortality available to us is through the ideas we pass on, the people we influence, the changes we make that outlast our individual lives." "That's the inheritance," David said. "That's the inheritance." In his journal that night, David wrote his final entry for the year. "I started this journey thinking critical thinking was an individual skill, something you learn to make yourself better. Now I understand it's a social practice, something we build together, teach each other, institutionalize through culture and systems." Sarah gave me this gift, the ability to see my own thinking, to question my certainties, to make better decisions. But the gift came with responsibility, to pass it on, to teach others, to create environments where clear thinking can flourish. That's what inheritance means. Not just receiving something valuable, but accepting the obligation to preserve and share it, to be a link in a chain of understanding that extends before and after our individual lives. I think about Emily, who was crying in a conference room 6 months ago and is now teaching others. I think about the systems we've reformed, the students we've trained, the culture we're slowly shifting. None of this is perfect. I still make mistakes. Students still struggle. Institutions still resist change. But the trajectory is clear. More people thinking more carefully about more things. Small improvements compounding over time. Sarah's mother had it right. This is how we survive death. Not our names or achievements, but our ideas. Not what we accomplish alone, but what we enabled others to accomplish. The critical thinking skills I've learned, they'll outlast me. They'll live on in students who become teachers, in systems that shape future physicians, in cultures that value clear thought over comfortable certainty. That's legacy. That's inheritance. That's why this work matters. I'm ready to carry it forward, not perfectly, but persistently, with humility, courage, and hope, one student at a time, one decision at a time, one generation at a time. The work continues. David closed the journal and looked at the stack of student reflections on his desk, assignments from his first semester teaching. Each one represented a mind opening, a perspective shifting, a person beginning their own journey toward clearer thinking. Tomorrow, he'd read them all. Tomorrow, he'd plan next semester's curriculum. Tomorrow, he'd continue the work Sarah had begun, that her mother had begun before her, that stretched back through generations of people who believed thinking well mattered. Tonight, he simply sat with gratitude for Sarah's teaching, for the journey he'd taken, for the opportunity to pass these gifts forward. The inheritance was his now, the responsibility to teach, to model, to reform, to persist. He would honor it, not perfectly but faithfully, the way Sarah had, the way her mother had, the way he would teach others to do. The chain of understanding continued. The legacy lived on. That was enough. That was everything. Epilogue. The beginning. 5 years later, Dr. David Okonkwo stood in the same lecture hall where he'd first attended Sarah Chen's seminar on critical thinking. But today, he wasn't a student. He was receiving the hospital's Teaching Excellence Award, presented annually to faculty who'd made exceptional contributions to medical education. The room was packed. Students he'd taught, colleagues he'd worked with, administrators whose systems he'd helped reform. Sarah sat in the front row, her hair grayer now, but her eyes as sharp as ever. "When I started residency," David said, accepting the award, "I thought I knew how to think. I was smart, well-educated, confident. I was also wrong about half the things I was confident about. I just didn't know I was wrong, which made me dangerous." A ripple of knowing laughter moved through the audience. Dr. Chen taught me something crucial. Intelligence and clear thinking are different things. You can be intelligent and still think poorly. You can have vast knowledge and still make terrible decisions. Because thinking isn't just what you know. It's how you process what you know, how you question what you think you know, and how you respond when what you know turns out to be wrong. He looked at Sarah. She taught me to see my own thinking, to notice when I was jumping to conclusions, falling into biases, letting emotions override analysis. She taught me that certainty is often a warning sign, not a confirmation, that the phrase, "I don't know," is sometimes the most honest and important thing a doctor can say. But more than that, she taught me that critical thinking isn't just an individual skill. It's a cultural practice. It's something we build together through how we teach, how we give feedback, how we structure our institutions, how we respond to errors and uncertainty. David gestured to the audience. Many of you in this room have been part of that work. You've reformed teaching rounds, redesigned M&M conferences, implemented reflection practices, created systems that make good thinking easier and bad thinking harder. You've done the unglamorous work of institutional change. This award isn't really mine. It belongs to all of us who committed to thinking more carefully about how we think. After the ceremony, a small group gathered at the coffee shop where David and Sarah had met so many times over the years. Rebecca Torres was there, now an attending psychiatrist who'd integrated critical thinking training into the psychiatry residency. James Patterson had become head of radiology and implemented structured reasoning protocols. Emily Zhang, now a third-year resident, was helping David teach the critical thinking seminar. Remember when only 40 people stuck with the course? Rebecca said, raising her coffee cup, "Now we can't fit everyone who wants to take it. Remember when Morrison said it was a waste of time?" James added, "Last month he asked me to help him implement our decision frameworks in the surgery department." They laughed, swapped stories about successes and failures, debated refinements to teaching methods. The conversation had the easy flow of people who'd worked together on something meaningful for years. Sarah mostly listened, occasionally offering observations, but largely letting the group carry the discussion. David noticed she seemed tired, more so than usual. When others had left, he stayed behind with Sarah. "Are you okay?" "I'm fine. Just thinking about how much has changed since that first lecture you attended. You were so earnest, so eager, so certain you could fix yourself through sheer intellectual effort." David smiled. "I was naive." "You were hopeful. That's different." Sarah finished her coffee. "David, I need to tell you something. I'm retiring at the end of the year. For real this time." "Because of your mother?" "Partly. She's declining faster now. I want to spend the time she has left being present, not distracted by work. Sarah paused. But also because it's time. I've done what I can do. The work is in good hands. Your hands and others like you. David felt a mix of sadness and understanding. What will you do? Read. Travel, maybe. Spend time with my mother while she's still here. And write. I've been thinking about documenting what we've learned about teaching critical thinking for the people who come after. That sounds good. It does, doesn't it? Sarah smiled. I'm ready. I've spent 25 years teaching people to think clearly. Now I want to think clearly about what I want to do with whatever time I have left. Practice what I preach. They sat in comfortable silence for a moment. Thank you, David said finally, for everything, for seeing something in me when I was just an overconfident resident, for teaching me to question myself without destroying myself, for showing me that this work matters. You did the learning. I just provided frameworks and asked questions. You did more than that. You showed me what it looks like to live a life committed to clear thinking and honest teaching. That's not a small thing. 6 months later, David stood in front of a new cohort of medical students for their first critical thinking seminar. He'd refined the curriculum over 5 years, but the core remained, helping people see their own thinking, question their certainties, practice better decision-making. I want to start with a question, David said. How many of you think you're good at thinking critically? Most hands went up. David smiled. He remembered raising his own hand to that question 5 years ago, confident in abilities he didn't actually have. Here's a better question. How many of you think you could be wrong about whether you're good at thinking critically? Fewer hands. Nervous laughter. That's where we start, with the recognition that we're not reliable judges of our own thinking quality, that confidence and competence don't correlate the way we expect, that the very biases that degrade our thinking also hide themselves from us. He told him about his first case with Sarah, about the meningioma he'd almost missed because he'd been so certain it was migraines, about the biomarker study he'd critiqued, about the fire that tested his thinking under extreme pressure, about the failures and the recoveries. I'm going to teach you frameworks and techniques. But more importantly, I'm going to teach you to see yourselves thinking, to notice when your brain is taking shortcuts, making assumptions, protecting your ego at the expense of truth. That's uncomfortable work. Some of you won't like it. Some of you will drop the course. But those who stay, who do the work, you'll become different kind of doctors, the kind who catch errors before they become tragedies, who make better decisions under uncertainty, who keep learning throughout your careers because you never assume you finish learning, the kind of doctors your patients deserve. An hour into the session, a student raised her hand. Dr. Okonkwo, you keep talking about mistakes you've made. Doesn't that undermine your credibility as a teacher? David considered the question. What do you think? I don't know. On one hand, it makes you seem more relatable. On the other, maybe we should learn from people who figured it out, not people who are still making mistakes. Good critical thinking on that question, David said. Let me respond with another question. Do you want to learn from someone who claims perfection and hides their failures? Or from someone who shows you what the learning process actually looks like, including the parts where you mess up and have to figure out how to do better? The student thought about it. The second one, I guess, because the first one is probably lying. Exactly. Anyone who claims they've mastered critical thinking and no longer make thinking errors is demonstrating that they haven't actually mastered it, because true expertise includes knowing the limits of your expertise. That evening, David video called his sister Chioma in London. She'd thrived there, been promoted twice, and was now consulting with companies on organizational decision-making. I'm stealing your frameworks, she told him cheerfully. The Steele-Manning technique is brilliant for stakeholder conflicts. The decision analysis structure prevents analysis paralysis. My clients love it. Steal away. That's how good ideas spread. They talked about their father, whose business had survived the economic changes they'd argued about years ago, partly by adapting more flexibly than competitors. They talked about Emeka, their younger brother, now in law school and applying critical thinking frameworks to legal reasoning. You know what's weird? Chioma said, critical thinking has become our family language. Like, we all talk differently than we used to. We challenge each other more. But it doesn't feel like fighting. It feels like collaborating toward better understanding. That's the culture shift. It spreads person to person, relationship to relationship. After hanging up, David reflected on how far the impact had rippled. Students teaching students, physicians reforming departments, family members influencing each other, each person becoming a node in a network of better thinking. A year after Sarah's retirement, David received an email from her. She'd finished a book, a guide to teaching critical thinking in medical education, full of frameworks, case studies, mistakes to avoid, and hard-won wisdom. "I want you to write the foreword," Sarah's email said. "You're the proof of concept, someone who learned these skills and used them to teach others, to reform institutions, to create lasting change. Tell that story." David spent weeks on the foreword. He wanted to capture what the journey had actually been like. The discomfort of examining your own thinking, the humility of realizing how often you've been confidently wrong, the slow accumulation of skills and insights, the responsibility that came with seeing clearly. He wrote about Margaret Foster, the patient who'd asked him to make her end-of-life decision, about the mass casualty fire that tested his thinking under impossible pressure, about Emily Zhang crying in a conference room and later teaching others, about the systems reformed and the culture slowly shifting. "Critical thinking," he wrote, "isn't a destination you reach. It's a practice you commit to imperfectly and persistently, for as long as you're making decisions that matter. Dr. Chen taught me that. She taught me to see my own thinking, to question my certainties, to build better systems for collective decision-making. But more than that, she taught me that this knowledge creates responsibility. Once you understand how to reduce preventable harm through clearer thinking, you can unknow it. You can't go back to accepting careless thought as inevitable. You have to act on what you know, by teaching others, by reforming systems, by persistently working toward environments where clear thinking can flourish. This book is part of that work. It's Dr. Chen passing on what she's learned, so others can build on it, improve it, adapt it, and pass it forward. That's how knowledge grows. That's how cultures change. That's how we create the future we want to live in. One thoughtful decision at a time. One reform system at a time. One generation of teachers and students at a time. The work continues. This book is an invitation to join it. On a cool autumn evening 3 years later, David sat in the same coffee shop where he and Sarah had met so many times. He was reviewing student reflections from his latest seminar when he received a call from Sarah. "My mother passed away this morning," she said, her voice steady but sad. Peacefully. "She'd stopped recognizing anyone weeks ago, but I'd like to think she knew I was there." "I'm so sorry." "Don't be. It was time. She was ready." Sarah was quiet for a moment. "I'm calling because I want to thank you for carrying forward the work, for teaching it better than I did, for building on it in ways I never imagined." "Sarah, let me finish. My mother taught me to think clearly and to value truth over comfort. I taught you. You've taught hundreds of others. Those hundreds will teach thousands. The ideas compound, improve, spread. That's the only immortality available to us. The ideas we set in motion that outlive us." She was right about that. David said quietly. She usually was. Even at the end, when she couldn't remember my name, she'd sometimes have these moments of clarity where she'd say something profound. Last month, she looked at me and said, "Did you teach them?" I said yes. She smiled and went back to wherever she goes. But she'd gotten her answer. The teaching had happened. The knowledge was passed on. They talked for a while longer, about memories, about Sarah's mother's remarkable life, about the legacy of ideas and practices that outlasted individual lives. After hanging up, David sat with his coffee and his student reflections. One caught his eye. "Before this course, I thought being a good doctor meant knowing the right answers. Now I understand it means knowing how to think carefully about uncertain situations. Dr. Okonkwo showed us that intelligence without humility is dangerous, that confidence without careful reasoning is harmful, that the hardest and most important thinking happens when we're willing to question ourselves. I don't know if I'll be a great doctor, but I know I'll be a thoughtful one. That's a start." David smiled. Yes, that was a start. And starts were all anyone ever really had. the beginning of understanding, the beginning of improvement, the beginning of teaching others what you learned. Every end was also a beginning. Sarah's mother's death was the end of her life, but the beginning of how people would remember and honor her teaching. Sarah's retirement was the end of her career, but the beginning of new forms of influence through her book. David's award was the end of one phase of work, but the beginning of the next. There were no final chapters in this story, no conclusions, just ongoing practice, persistent effort, continuous learning and teaching and refining and passing forward. The art of critical thinking wasn't something you mastered and completed. It was something you practiced, shared, built into systems and cultures, and handed to the next generation as a gift and a responsibility. David opened his laptop and started writing his lesson plan for next week's seminar. New students, new cases, new opportunities to help people see their own thinking. The work continued. It always would. And that was exactly as it should be. The beginning, forever renewable, forever necessary, forever worthy effort. He smiled and kept writing. For everyone who ever learned to question their certainties, examine their biases, and think more carefully about what matters. For everyone who teaches these skills to others. For everyone who builds systems that make clear thinking more likely. The work continues. Join it. Dio.